ഹലോ. 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 ഡോക്ടർ വിഷ്ണു മോഹൻ കേറിയായിരുന്നു. കേൾക്കുന്നുണ്ടോ? കണക്ട് ആകുന്നതേ ഉള്ളൂ എന്ന് തോന്നുന്നു. ഹലോ. സ്ക്രീൻ ഷെയർ ചെയ്യുന്നുണ്ടോ? ചെയ്യാൻ പറ്റുന്നുണ്ടല്ലോ അല്ലേ?
ഉണ്ട് മാം. കളി സ്റ്റോപ്പ് ചെയ്ത്
ശരി.
വെച്ചേക്കായിരുന്നു.
ഓ, ഞാൻ നോക്കുന്നത്. അപ്പം
ആ
സ്ലൈഡ് മാറുന്നുണ്ട്. ഒരു ബ്ലാക്ക് പോലെ കാണുന്നുണ്ട് അതിനകത്ത്.
ആണോ, ഒരു സെക്കൻഡ്.
ഫ്രണ്ടിൽ കുറച്ച്
കാണാവോ?
കുറെ കാണാം, പക്ഷെ
ആ,
കുറെ വിൻഡോസ് ഇങ്ങനെ ബ്ലാക്ക് ബ്ലാക്ക് ആയിട്ട് വന്ന് കിടക്കുന്നുണ്ട്. അത് എനിക്ക് മാത്രം തോന്നുന്നതാണോ എന്ന് അറിഞ്ഞൂടാ. ആ,
ആണോ ഇപ്പൊ?
ഒരു സെക്കൻഡ്. ഐശ്വര്യ, അങ്ങനെയല്ലേ കാണുന്നത്?
ആ
ഇപ്പൊ
മാഡം
എങ്ങനെയാണ്?
അങ്ങനെയാണ്.
അങ്ങനെയാണ് കാണുന്നത്. So, ഒന്നും കൂടെ ഒന്ന് ക്ലോസ് ചെയ്തിട്ട് വേറെ
ഒന്നുകൂടെ
ഏതെങ്കിലും വിൻഡോസ്
നോക്കട്ടെ.
ഓപ്പൺ ആയി കിടപ്പുണ്ടോ?
ഒന്ന് നോക്കട്ടെ. ഇപ്പോഴോ മാം? ഇപ്പൊ എങ്ങനെ കാണാൻ പറ്റുന്നുണ്ടോ?
ഔട്ടായി പോയിന്ന് തോന്നുന്നല്ലേ സാറ്?
അതെ മാഡം, ലെഫ്റ്റ് ആയി.
ലെഫ്റ്റ് ആയി. കുറച്ചൊരു റേഞ്ച് കുറവുള്ളൊരു സ്ഥലമാണ്.
ഓക്കെ.
നേരത്തെയും അങ്ങനെ ഉണ്ടായിട്ടുണ്ട്, പക്ഷെ കേറിയായിരുന്നു, പക്ഷെ കണക്റ്റ് ആയിട്ടില്ല എന്ന് തോന്നുന്നല്ലേ. കോഹോസ്റ്റ് ആക്കി, പക്ഷെ അത് കണക്റ്റ് ആയില്ല എന്ന് തോന്നുന്നു. ഓഡിയോ കണക്റ്റ് ആയില്ല എന്ന് തോന്നുന്നു അല്ലേ.
അതെ മാഡം.
അല്ല, അതങ്ങനെ അങ്ങനെ വരാൻ എന്താ കാര്യമെന്ന് അറിയില്ല അല്ലേ. അത് സ്ക്രീൻ ഷെയർ ചെയ്തിട്ടും
മാഡം ഇപ്പൊ സ്ക്രീൻ ഓക്കെ ആണല്ലോ.
ഒരു സെക്കൻഡ്. സ്ക്രീൻ ഇപ്പോൾ ഓക്കെയാണ്, സ്ക്രീൻ ഇപ്പോൾ ഓക്കെയാണ്. ഓഡിയോ കണക്റ്റ് ആണോ എന്തോ? ഓഡിയോ കണക്റ്റ് അല്ല എന്ന് തോന്നുന്നു. കേൾക്കുന്നുണ്ടോ സർ? ഹലോ, കേൾക്കുന്നുണ്ടോ? കേൾക്കുന്നില്ല.
മാം കേൾക്കാം. അതെ.
കേൾക്കാം കേൾക്കാം. ശരി ശരി. സ്ലൈഡ്
ശരിയായോ സ്ക്രീൻ?
ശരിയായി ശരിയായി. സ്ലൈഡ്
ഓക്കെ.
ഷെയറിലിടുവോ?
ഇടാം.
സ്ലൈഡ് ഷെയർ.
അതെ. ശരി.
യെസ് 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 യെസ്. സ്ലൈഡ്
കാണാലോ
മൂവ്
അല്ലേ?
ചെയ്യുന്നുണ്ട്. കാണാം കാണാം കാണാം.
ഓക്കെ. ഞാൻ അത് കുറച്ച്
ഓക്കെ.
സോർട്ട് ഔട്ട് ചെയ്ത് നോക്കിക്കൊണ്ടിരിക്കുകയായിരുന്നു.
നമുക്ക് അടുത്ത സ്ലൈഡിലോട്ട് മാറ്റി നോക്കോ. മാറ്റാനും കുഴപ്പമില്ല.
വരുന്നുണ്ടല്ലോ അല്ലേ?
വരുന്നുണ്ട് വരുന്നുണ്ട്.
ഓക്കെ.
നമുക്ക് ഒരു 2 മിനിറ്റ്സിൽ തുടങ്ങാം.
ഓക്കെ മാം. മാം പറയുന്ന പേപ്പർ തുടങ്ങും. സ്റ്റാർട്ട് ചെയ്യും.
ഓക്കെ, നമുക്ക് 2 മിനിറ്റ്സിൽ തുടങ്ങാം. യു നോ ദാറ്റ് ക്ലാസ്സസ് ആർ റെക്കോർഡഡ്, അതുകൊണ്ടാണ് നമ്മൾ സമയത്തിന് തുടങ്ങുന്നത്. സോറി, എന്നെ സൗണ്ട് എനിക്ക് സംസാരിക്കാൻ ബുദ്ധിമുട്ടുണ്ട്, ബിക്കോസ് ഐ എം നോട്ട് വെൽ. അപ്പോൾ ഇന്നത്തെ ക്ലാസ് ഡോക്ടർ വിഷ്ണു മോഹൻ, ഹീസ് എ വെരി എസ്റ്റീംഡ് ഫാക്കൽറ്റി. ഹീസ് കറൻ്റ്ലി ഡൂയിങ് ഹിസ് റെസിഡൻസി, ദാറ്റ് ഇസ് ദ DM at CMC Vellore. So DM in neonatology CMC Vellore. ഹീസ് എ നമുക്ക് കഴിഞ്ഞ പ്രാവശ്യം ഒരുപാട് ക്ലാസ് നമുക്ക് എടുത്തിട്ടുണ്ടായിരുന്നു. ആ ക്ലാസ്സുകളെല്ലാം തന്നെ വളരെ യൂസ്ഫുൾ ആയിരുന്നു. അതുപോലെ തന്നെ ക്വസ്റ്റ്യൻസ് പലതും പീഡിയാട്രിക്സിലെ ക്വസ്റ്റ്യൻസ് മറ്റ് മെഡിസിനുമായിട്ടും ബാക്കിയുള്ളവർക്കായിട്ട് ബന്ധപ്പെട്ട് നമുക്ക് ഒരുപാട് ക്വസ്റ്റ്യൻസ് ആൻസർ ചെയ്യാൻ പറ്റും ഈ ഡിസ്കഷൻസ് വെച്ച് തന്നെ. ഇറ്റ്സ് വെരി ഡിഫിക്കൽട്ട് ടു കവർ ഓൾ ദീസ് ഇൻ ദി ലാസ്റ്റ് ഫ്യൂ ഡേയ്സ്. അപ്പോൾ അതുകൊണ്ട് ഇന്ന് ക്ലാസ്സിൽ അറ്റൻഡ് ചെയ്യുന്നവർക്ക് ദിസ് വിൽ ബി എ വെരി ഗുഡ് എക്സ്പീരിയൻസ്. ആൻഡ് നിങ്ങൾക്ക് കുറേ കാര്യങ്ങൾ ഇതുകൊണ്ട് ഓർത്തിരിക്കാൻ പറ്റും. ആൻഡ് ഐ നോ ദാറ്റ് അപ്പോൾ നമുക്ക് അറിയാം, വി ഹാവ് സോ മച്ച്, എന്താ പറയുക, വി ഹാവ് സോ മച്ച് ഹോപ്പ് ഇൻ ദിസ് ബാച്ച്. നമുക്ക് നല്ല റാങ്ക് കിട്ടും എന്നാണ് പ്രതീക്ഷയുള്ള കുറേ പേര് ഇതിനകത്തുണ്ട്. സോ എനിവേ, ഇഫ് ദേ കനോട്ട് വാച്ച്, ദേ വിൽ ബി വാച്ചിങ് ദി റെക്കോർഡിങ്സ്, ബട്ട് വി നോ ദാറ്റ്സ് വെരി ഡിഫിക്കൾട്ട്. So thank you. And he was having hectic duties in spite of all these things. He came today to take class. So thank you. Over to you, Dr. Vishnu. തുടങ്ങാം.
തുടങ്ങാം. Thank you so much, ma'am. So, ഞാൻ പറഞ്ഞ പോലെ this is my third session with IMA. കഴിഞ്ഞ 2 വർഷം ഞാൻ എടുത്തിരുന്നു. So, it's my honor and സ്വപ്ന മാം ഭയങ്കര ഒരു അപ്രോച്ചബിൾ ആയിട്ടുള്ള ഒരാളാണ്. കഴിഞ്ഞ 20th ആണ് ആക്ച്വലി ക്ലാസ് സ്കെഡ്യൂൾ ചെയ്തത്, ബട്ട് ബിക്കോസ് ഓഫ് all the sudden issues and duties and all, we have to postpone this class. But thank you so much, ma'am. നമുക്ക് ഓൾറെഡി സമയം കുറച്ചിലാകാൻ തോന്നുന്നു. So, I'll start. Audible അല്ലേ എല്ലാവർക്കും?
Yes, audible.
Sure. Okay. So basically we all know, നമ്മളൊന്ന് ഡിസ്കസ് ചെയ്യാൻ പോകുന്ന പീഡിയാട്രിക്സ്. പീഡിയാട്രിക്സ് എന്ന് പറയുന്ന ഒരു ബ്രാഞ്ച് നമ്മളൊരു നീറ്റ് പെർസ്പെക്റ്റീവിൽ നോക്കിക്കഴിഞ്ഞാൽ ആ വെയിറ്റേജ് മേ നോട്ട് ബി ദാറ്റ് അത്രയൊരു ഹൈ വെയിറ്റേജ് ഉള്ള സബ്ജക്റ്റ് ആവണമെന്നില്ല. പക്ഷേ ഈ പീഡിയാട്രിക്സുമായിട്ട് ബന്ധപ്പെട്ട് കിടക്കുന്ന കുറേ സാധനങ്ങൾ നമ്മൾ വേറെ പല സബ്ജക്ട്സിൽ നമ്മൾ എൻകൗണ്ടർ ചെയ്യാറുണ്ട്. പാത്തോളജിയിൽ ജനറ്റിക്സ് നമ്മൾ കാണുന്ന പോലെ, ഇപ്പോൾ മെറ്റബോളിക് ഡിസോർഡേഴ്സ് നമ്മൾ മെഡിസിനിൽ കാണും. സോ പീഡിയാട്രിക്സും ഈ കാര്യങ്ങളൊക്കെ ഒരുമാതിരി എന്താ കൂട്ടിച്ചേർന്ന് കിടക്കുന്ന ഒരു ഐറ്റമാണ് പീഡിയാട്രിക്സ്. സോ സബ്ജക്ട് വൈസ് നമുക്ക് പല വ്യത്യാസങ്ങളും ഉണ്ട്. ഇപ്പോൾ നമ്മൾ സാധാരണ മെഡിസിനോ സർജറി പഠിക്കുന്നത് അല്ലാതെ തന്നെ ഒരുപാട് എക്സ്ട്രാ കാര്യങ്ങൾ, ഗ്രോത്ത്, ഡെവലപ്മെന്റ്, ന്യൂട്രീഷൻ ഒക്കെ എക്സ്ട്രാ ഉള്ള സബ്ജക്റ്റും കൂടെ ആയതുകൊണ്ട് പല സമയത്തും നമ്മൾ ശ്രദ്ധിക്കാനുള്ള ഒരു പാറ്റേൺ എൻട്രൻസ് എക്സാംസിൽ എപ്പോഴും വളരെ ദേ വിൽ ഓൾവേസ് കോൺസെൻട്രേറ്റ് ഓൺ ദ ബേസിക്സ്. സോ ബേസിക്സ് ആണ് പീഡിയാട്രിക്സിന്റെ നമ്മളെപ്പോഴും ഒരു എക്സാം ആസ് ഫ്രം എ UG point of view perspective, when you go for an entrance exam, you should be thorough with the basic rather than the systemic part or the high core part. So we'll start without much ado. നമ്മൾ പറഞ്ഞ പോലെ ബേസിക്സിൽ തന്നെ സ്റ്റാർട്ട് ചെയ്യാം. So the first question, this was a repeated question. കഴിഞ്ഞ ഒരു 15 years 3 തവണ ചോദിച്ച ക്വസ്റ്റ്യൻ ആണ്. WHO defines adolescent age between what? So 10 to 19 years, 10 to 14 years, 10 to 25 years, and 9 to 14 years. So WHO defines adolescent age to be between 10 to 19 years. Okay, this is a very important thing. Usually, we have adolescence distinguished into 3 categories. There is an early phase of adolescence, there is a mid phase of adolescence, and there is also a late phase of adolescence. ഇതിൽ നമ്മുടെ 10 to 13 years എന്ന് പറയുന്നതാണ് early adolescence, 14 to 16 years is called mid adolescence, and 17 to 19 years is when what we call as late adolescence, which usually happens after the pubertal area. So pubertal phase. So ഈ ഒരു കാര്യം പറയുമ്പോൾ you should also remember certain other definitions which should be kept in mind. So what is the definition? Conventionally നമ്മൾ ഒരുപാട് യൂസ് ചെയ്യുന്ന കുറേ ടേംസ് ഉണ്ട് അല്ലെ, ഓവം, സൈഗോട്ട്, ഫീറ്റസ്, ഇൻഇനേറ്റ് ഇൻഫന്റ്. So you should also be thorough with what everything means. Okay, so what is an ovum? So ovum is basically from the point of conception to 2 weeks after fertilization. That period is what is called as an ovum. And zygote is from the 15th day of conception to 8 weeks of gestation. Fetus, again, this is a repeatedly asked question. What is the age criteria for a fetus? So fetus usually starts from the 9th week of gestation up till the period of birth. Okay, 9th week of gestation to the period of birth is called a fetus. And the perinatal period എന്ന് വിളിക്കുന്നത് എന്താണ്? 22nd week of gestation until the 7th day of postnatal day is called the perinatal period. And neonate, neonate is the first 4 weeks of life. Usually the first 28 days of life after a baby is being born is what we term as a neonate. And an infant is up to 1 year of age. 1 to 3 years is called a toddler. 3 to 6 years is called a preschool age group. And school age is 6 to 12 years, and adolescence is between 10 to 19 years. So ഈ adolescence ആണ് നമ്മൾ നേരത്തെ early adolescence, mid adolescence, and late adolescence ആയിട്ട് തിരിച്ചത്. Okay, I hope everyone is clear with this. Move to the next question, a very simple question. 90% of brain growth is achieved by what age? Again, time to time repeat ചെയ്ത് വരുന്ന ഒരു topic ആണ് growth and development, especially the graphs regarding various tissues of growth. Okay, അതിൽ ഏറ്റവും ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള സാധനമാണ് brain growth. So what age is when 90% of the brain growth is achieved? To know this, you should know this graph. This graph sums up the rates of growth of all the important tissues inside the body. നമുക്കറിയാം brain growth in the graph ഉണ്ട്. There is a growth for the general growth, or for the S-shaped growth or somatic growth. There is a growth curve for the lymphoid tissue growth, and there is a growth curve for the reproductive tissue growth. So if you see this, so നമുക്കറിയാം, let's see the growth for brain. Usually when you notice this is the graph for the brain growth curve. Okay, so when you notice this, usually The brain growth curve starts from birth and there's an exponential rise till a period of 2 to 3 years. Okay. Adinishation, sorry, this is the graph. So 2 to 3 years, after which there is a plateau phase and it kind of stabilizes. If we can notice, exponential rise till the age of 2 to 3 years, after which it stabilizes and then it plateaus. So that is how the brain growth goes. So from this question, 90% of the brain growth is achieved by what years? ഏകദേശം നമുക്ക് നോക്കാം 2 വയസ്സാകുമ്പോൾ ഓൾമോസ്റ്റ് 90% is achieved. കണ്ടോ, almost 90%. After this, it's going to be a small rise and then it's going to be a plateau phase. Now, along with this, you should also know what are the growth patterns of other tissues. In നേരത്തെ പറഞ്ഞ പോലെ, the general growth or the somatic tissue growth pattern is going to be something like an S-shaped curve. If you can notice, this is kind of an S-shaped curve. If you can trace this graph, so you can notice that there is an initial spot of growth which goes on till the age of around 3 years. And ഒരു 3 വയസ്സ് വരെ there's initial spot of growth which undergoes, after which there is a plateau phase which goes till the age of 10 to 11 years. Then by the action of pubertal hormones, there is again a spot of growth which goes till the age of 17 to 18 years. So typically, if you're asked to describe what the shape of a somatic growth is, it is kind of a sigmoid shape or an S-shaped growth curve. Okay. Next, what is the typical pattern of reproductive growth tissue, tissue growth? So again, reproductive tissue growth and വളരെ subtle growth pattern. You can notice that it starts from birth, and then because the hormonal effect is very silent, it goes on subclinical till the age of 9 to 10 years, after which the prepubertal phase starts. പിന്നെ അങ്ങോട്ട് ഒറ്റയ്ക്ക് ഏറ്റവും. You can notice this, right? So this is how the reproductive, this is when the pubertal phase begins, and this goes on like this. So it is very easy if you know the concept. So reproductive tissue growth is like this, okay? And then you have the lymphoid tissue. Lymphoid tissue, remember that basically lymphoid tissue will have kind of a small peak at the age of around 3 to 4 years. You can notice ഇതിങ്ങനെ സ്റ്റാർട്ട് ചെയ്ത് ചെറിയൊരു പീക്ക് പോലെ വന്നിട്ട്, but the major peak will happen at around the age of 8 to 10 years, again because of hormonal influence. So it's kind of a twin peak, but the first peak is not very visible. So lymphoid tissue will have a very peak growth at around 10 years, after which you can notice that it regresses. So the lymphoid tissue growth, after a phase of rising, it will regress and come back to its original position by around 14 to 15 years. So you should keep this graph in your mind, because this is one area. Ella entrance exams, there has been questions. Kind of version they asked regarding the somatic growth curve. I remember the version they asked about the brain growth. So this graph is something which you should always keep in your mind. And the question, the answer on the 90% of the brain growth will be achieved by the age of 2 years. Correct. Okay. Next, we'll go to the question. Again, another basic anthropometry, very favorite topic of the examiners. Height of a child is double the birth length at the age of. Okay, what is the answer? So, what is the average length at birth for a normal term born baby? The average length at birth usually is around 50 centimeters. And then you should know how the length ideally increases. Okay, it usually increases 25 centimeters in the first year of life, and it becomes at around 3 years 90 centimeters. This is for a normal baby under an ideal circumstance. Ella babies this is just an ideal circumstance, and roughly we say that the length at which the baby has been born will double by the age of 4 years. Okay, and after that, you should also remember this thing. There is something called height velocity. So what is height velocity? Height velocity is the increase in length or height per year. Okay. So usually until puberty, after this, the height will increase by around 5 centimeters per year. അതിനുശേഷം ഞാൻ നേരത്തെ പറഞ്ഞ നമ്മുടെ somatic growth curve ഓർമ്മയുണ്ടല്ലോ. So growth spurt after the pubertal phase will be very high. So around 9 to 10 centimeters per year for the next 2 to 3 years. So in the answer എന്തായിരിക്കും? So when, at what age will the length of a height of a child double? It will be usually by 4 years of age. Okay, at around 4 years, you will roughly have the length of the baby or a child doubling. So these are the other important nuggets which you have to keep in mind. The birth weight is usually doubled by 5 to 6 months, triples by 1 year, and quadruples by 2 years. Then you should also remember this. There is something which is called a USLS ratio. What is USLS ratio? The USLS ratio means upper segment is to lower segment ratio. That if you have to measure from the head, the vertex of the head to pubic symphysis, and from the pubic symphysis down to the feet, the ratio will be, upper segment will be from the head to pubic symphysis, and lower segment will be from the foot symphysis up to the heel of the foot. Okay, so this ratio is very important. Normally, this ratio at birth will be 1.7 is to 1. Okay, 3 years 1.3 is to 1. So at birth, upper segment will be more than the lower segment. If you can notice, upper segment will be more than the lower segment at birth, and after birth, it usually starts decreasing. For adult, usually normally it will be around 0.9 is to 1. The lower segment will have a marginal advantage over upper segment when it comes to an adult, and it is usually attained in more than 10 years. Okay, and again, what is the average head circumference at birth? It is around 35 centimeters. So, Adinishation head circumference will usually increase by 2 centimeters per month in the first 3 months, 1 centimeter per month in the next 3 months, and by around 0.5 centimeters per month in the next 6 months. So you should know how the normal trajectory of all the anthropometric measurement goes. Okay, especially the weight, height, the upper second percent ratio are our favorite questions. We'll talk about USLS ratio more when we deal with short stay. So ഞാൻ നേരത്തെ പറഞ്ഞ പോലെ തന്നെയാണ്. And you should also think this is called the Veach formula. നമ്മളെല്ലാം bedside clinical case taking, you'll use that. Okay, this is a rough formula to calculate the expected weight of the child based on the age. Okay, I think all of you will be familiar with this. So anthropometric measurements, when we talk about anthropometric measurements, we should know something which are called age independent anthropometric measurements. Okay, so എന്താണ് ഏജ് ഇൻഡിപെൻഡന്റ് ആന്ത്രോമെട്രിക് മെഷർമെന്റ്സ്? സോ നമ്മൾ നേരത്തെ പറഞ്ഞു വെയിറ്റ്, ലെങ്ത്, ഹൈറ്റ്, ഹെഡ് സർക്കംഫറൻസ്, ഇതൊക്കെ ഏജ് ഡിപെൻഡന്റ് ആന്ത്രോമെട്രിക് മെഷർമെന്റ്സ് ആണ്. ദാറ്റ് ഈസ് വിത്ത് ഏജ്, അതായത് നമുക്ക് ഇപ്പോൾ 1 വയസ്സിലുള്ള വെയിറ്റ് ആയിരിക്കില്ല 2 വയസ്സിലുള്ളപ്പോൾ, അല്ലെ 3 വയസ്സിലുള്ളപ്പോൾ വെയിറ്റ് ആയിരിക്കില്ല 4 വയസ്സിലുള്ളപ്പോൾ. അതേപോലെ വെയിറ്റ്, ലെങ്ത് ആൻഡ് ഹെഡ് സർക്കംഫറൻസ് കീപ്സ് ഓൺ ചേഞ്ചിങ് വിത്ത് ഏജ്. But there are certain measurements or certain parameters which are independent of age. അതായത് the parameters, these parameters in the cutoff won't change with age. That is, even if you take a 1-year-old baby or if you take a 4-year-old child, the cutoff for these are going to remain the same, and these are called age-independent anthropometric measurements. So, what are some examples of age-independent anthropometric measurements? MUAC. And what is MUAC? What is MUAC? MUAC stands for mid upper arm circumference. SAM classification. MUAC is one method of grading severe acute malnutrition. So it is usually measured in the left upper arm or the non-dominant arm. So mid upper arm circumference is an age-independent anthropometric measurement. What is the cutoff? MUAC more than 13.5 centimeters is normal, irrespective of age, till 5 years of age. Okay. 5 വയസ്സിന് ശേഷം MUAC is not very reliable because അതിനുശേഷം muscle mass and all depends on various other factors. So till 5 years of age, the value or the cutoff for MUAC remains the same, be it a 6-month-old infant, be it a 2-year-old child or a 3-year-old child. If it is more than 13.5% measured on the left upper arm, it is going to be normal. And anything between 12.5 to 13.5 is mild malnutrition, 11.5 to 12.5 is moderate malnutrition, and anything less than 11.5 is called severe acute malnutrition. So that is MUAC. Second is a bangle test. Same thing, ഒരു bangle which has a diameter of around 4 centimeters. Normally, the bangle cannot pass through. നമ്മൾ bangle ഇങ്ങനെ കൈ കൂടി ഇടുമ്പോൾ forearmന്റെ മുകളിൽ കൂടെ the bangle cannot pass through. In a baby with malnutrition, the bangle can easily pass through. Again, it is based on the same concept of MUAC. Similarly, the old times there was a tape called the Sharper's tape, which graded colors into green, yellow, and red. Just like the MUAC tape. So basically, if the tape measurement comes to red color, it means that the baby is having severe malnutrition. Wax stick and body mass index. Again, BMI is an age-independent anthropometric measurement because it is basically a ratio. Right? BMI is not based on the age. BMI at a cutoff remains uniform for all age groups, correct? So it is a age-independent anthropometric measurement. If this has been asked previously, which of these is an age-independent anthropometric measurement? They are given weight, height, head circumference, and BMI. Obviously, the answer is going to be body mass index or BMI. Then there is also something called the contrast index, which is head circumference by length in weight, length raised to cube. Again, it is weight by height cube. So this is also a indicator for IUGR in newborns. So that is also an age-independent anthropometric measurement. Okay. So we go to the next question. Which of these is not a law of growth? Growth is an orderly and continuous process. Second, അത് കറക്റ്റ് അല്ലേ? ഓർഡർലി ആൻഡ് കണ്ടിന്യൂസ് പ്രോസസ് ആണ്. ഗ്രോത്ത് ഓൾവേസ് യൂഷ്വലി ഹാപ്പൻസ് ഇൻ an order. It doesn't happen haphazardly. There will be a particular order in which the growth will usually happen. The rate of growth is always uniform. And then growth always proceeds distally to proximally. Distally എന്ന് പറയുമ്പോൾ എങ്ങനെയായിരിക്കും? നമ്മുടെ ഇപ്പോൾ distally to proximal ഫിംഗർ ടിപ്സ് ആയിരിക്കും distal എങ്കിൽ നമ്മൾ മുകളിലോട്ട് കയറുന്ന it is proximal. So growth usually proceeds distally to proximal. It is correct. It is usually distal to proximal. That is the pattern how the growth proceeds. And again, it is usually cephalocaudal. Correct. Usually, usually it starts from the head and proceeds downwards. So growth is usually cephalocaudal direction. So which is one statement that is not correct in this. The rate of growth, നമ്മൾ നേരത്തെ പറഞ്ഞ സെയിം സാധനത്തിന്റെ ആപ്ലിക്കേഷൻ നമ്മൾ നേരത്തെ ഗ്രോത്ത് കർവ് പഠിച്ചു അല്ലെ, ഗ്രോത്ത് കർവ് ഫോർ ഡിഫറെന്റ് ഇഷ്യൂസ്. ഇൻ ദാറ്റ് വി ലേൺ ദാറ്റ് ദ റേറ്റ് ഓഫ് ഗ്രോത്ത് ഇസ് നോട്ട് യൂണിഫോം. നമുക്ക് ഓർമ്മയില്ല സിഗ്മോയിഡ് ഷേപ്പ് ഓഫ് സൊമാറ്റിക് ഗ്രോത്ത്. സൊമാറ്റിക് ഗ്രോത്ത് എങ്ങനെ എല്ലാ സ്ഥലത്തും ഒരേ റേറ്റിലാണോ? അല്ല. നമ്മൾ ആ തുടക്കത്തിൽ ഒരു ഗ്രോത്ത് ഉണ്ട്, അതിനുശേഷം പ്ലേറ്റ് ഓഫ് ഫീസ്, then again growth. There's an exponential growth. Similarly, brain growth and so the rate of growth is not always uniform. Other than this, all the statements are true when it comes to the laws of growth. Okay. And the next statement, you should also know about the rules of development. Growth in a pola thanne, there are similar rules for development. The difference arises in certain things. Development usually happens proximal to distal. Development usually happens proximal to distal. Okay. അതായത് initially baby will be able, for example, baby ki നമ്മൾ ഡെവലപ്മെന്റിന്റെ കാര്യം പറയുമ്പോൾ you will always notice initially baby will have wide express grasp, അതിനുശേഷം unit express grasp, അതിനുശേഷമാണ് pincer grasp വരുന്നത്. So generally they will be able to progress from proximal to distal, and there is something which is called generalization to specificity. They will be doing specific tasks at the end. Initially they will be doing generalized tasks at the beginning. And the development depends on the functional maturity of CNS. Correct, we can apply that, and it is also a continuous and orderly process. And usually there will be loss of primitive reflexes before attainment of relevant milestones. So then, for example, there is something which is called ATNR, asymmetric tonic neck reflex. So ATNR usually sets in by birth and will usually end by 5 months of age. So if this ATNR is there, baby can't roll over. ATNR ഉണ്ടെങ്കിൽ baby cannot roll over because it's a protective reflex. So once ATNR subsides, baby will be able to roll over. So this is a typical example of a primitive reflex giving way to a more mature reflex. And so these are the important rules of development. And there is one thing which is always controversial. The rule of development clearly states that the sequence of attainment of milestones is same in all children. Generally, this holds true, but in all cases, this is not true. Okay. Sometimes there are some developmental deviations can happen in certain children where the sequence of attainment milestones may be different. So that is why I've given this in black, because this is not a universally applicable thing, but in all the other statements of development are universally applicable. So you should, when you know the rules of growth, you should also know the rules of development. Only the main difference is being that growth usually occurs from distal to proximal. Distal to proximal is growth, and proximal to distal growth is development usually happens proximal to distal. Okay. And coming to the next question, again, examiners in the very important favorite topic. So a child is diagnosed to have short stature. Okay, diagnosed with short stature where the bone growth velocity is normal. Okay, so a child is below the third percentile for height. So the definition of short stature as such means that if the height of the child at the particular age for the particular sex is below the third centile, growth chart if it is less than the third centile, that is called short stature. So next we have given a catch that the growth velocity is normal. What is growth velocity? The rate of increase of growth of length or height per year. അല്ലെങ്കിൽ during a particular time frame, not necessarily year, ചില സമയത്ത് മാസങ്ങളാവും. So whatever time frame you're taking. So for during a particular time frame, the rate of increase in length or height is what you call as growth velocity. But the growth velocity is normal. Okay. But the chronological age. Chronological age means the actual age of the child, and bone age is the age of the bones. So whenever you suspect short stature for a child, bone age, you get the X-ray of wrist done for a child. You get the wrist X-ray done, or the wrist X-ray, you compare it with standard charts for corresponding bones. Okay, so that is how you see the bone age. അത്രയും പ്രായത്തിനുള്ള bone maturity കുട്ടിയുടെ ബോൺസിനുണ്ടോ? So they have given that the growth velocity is normal, chronological age is more than the bone age. What is the most likely diagnosis? Okay, When such a question comes up, you should always think what all points they have given in your question. Okay. So the first thing they are given is growth velocity is normal. So basically, in any pathological short stature, whether short stature can be physiological short stature, and a type 1 genetic short stature, and constitutional short stature. If growth velocity is abnormal, if they give that growth velocity is decreased, it is always going to be a pathological short stature, probably due to an endocrine cause. So growth velocity abnormal എന്ന് അവർ കൊടുത്തിട്ടുണ്ടെങ്കിൽ it is decreased, that always means it is a pathological short stature. Okay, so basically we have three types of short stature: familial short stature, constitutional short stature, and something which is called as a pathological short stature. നമ്മൾ ഈ പ്രോബ്ലി അസുഖങ്ങൾ കാരണം വരുന്നതിനെയാണ് ബേസിക്കലി സിംപ്ലി pathological short stature എന്ന് വിളിക്കുന്നത്. So in pathological short stature, always the growth velocity is going to be decreased. ഇനി നമുക്ക് ബാക്കിയുള്ള രണ്ടെണ്ണമാണ്. ഗ്രോത്ത് വെലോസിറ്റി നോർമൽ ആണെങ്കിൽ you have two other options. It can either be a constitutional short stature, or it can also be a genetic short stature, which is also called as a familial short stature. So familial short stature basically means it is inherited. Okay, it happens from the parents. Usually the parents will be having short stature, and because of which the child will also be short stature. In them, what will happen? In them, the growth velocity, height velocity will remain normal. പക്ഷേ the bone age will be equal to the chronological age. അതായത്, so the short stature is genetic, so which means that the bone age and the age of the child will be matching. അതിന് വേറെ പ്രത്യേകിച്ച് പ്രശ്നങ്ങളൊന്നുമില്ല. So the bone age will be matching the chronological age, but it will be more than the height age. So what is the next term, which is called as height age? So height age എന്ന് വെച്ചാൽ, suppose a child is having short stature, suppose his age is say 5 years, and you see his height, and his height is say corresponding only to an age of 3 years. മനസ്സിലായില്ലേ? ഒരു 5 വയസ്സുള്ള കുട്ടി, what is the expected height? 6x plus 1 അപ്ലൈ ചെയ്യുകയാണെങ്കിൽ ഇത് 107 centimeters. 5 വയസ്സുള്ള കുട്ടിയുടെ പക്ഷേ ആക്ച്വൽ ഹൈറ്റ് when you're measuring, it is only 80 centimeters. So when you see that 80 centimeters, the age of the child is going to be much lesser, 3 or 2. So that is going to be the height age. So when the height age is overtook by the bone age and chronological age, and both chronological age is equal to chronological age, because bone age എന്ന് പറയുന്നത് bone growth ന്റെ മെഷർമെന്റ് ആണ്. So bone growth is also not getting affected. At the same time, chronological age and bone age match ആവുന്നുണ്ട്. So it is typically a case of familial short stature. Now, the second thing is something which is called as a constitutional short stature, and this is the most common type of short stature. Familial short stature അല്ല most common type of short stature. Constitutional short stature is the most common type of short stature. Constitutional short stature എന്താ പറ്റുകയെന്ന് വെച്ചാൽ, the children, babies will be born normal. Okay, parents may or may not have short stature, but it is not genetic. So they'll be born normal. They'll usually grow normally till a period of 2 to 3 years. After this period of 2 to 3 years, they will have a period of growth retardation. This is usually due to bone growth not happening properly. This is usually due to the bone or the skeletal growth not happening properly. And this goes on, happens till the age of puberty, after which, due to pubertal hormones spurt, the growth again recovers, and finally they finish at the normal target height. So this is called constitutional short stature, where the bone age actually lags behind the chronological age. So if a condition is given and the chronological age is more than the bone age, and the bone age is equal to the height age with a normal height velocity, the answer is going to be a constitutional short stature. അപ്പോൾ ഞാൻ നേരത്തെ പറഞ്ഞ പോലെ height velocity decreased എന്ന ഒരു ക്വസ്റ്റിന് കൊടുത്തിട്ടുണ്ടെങ്കിൽ, and with the chronological age is much more than the bone age, height age, and the bone age, that is going to be a pathological short stature. So when you come back to this question, so in this question, they have clearly mentioned that the height velocity is normal, but chronological age is more than the bone age, which means that the skeletal growth is lagging behind. And the obvious answer, if the height velocity is normal with the chronological age more than the bone age, the answer is going to be constitutional short stature. If you see this graph, if you see this graph, initially growth is normal, then there's a small point of lagging behind, after which it catches up and finally reaches the normal target height. And if you see the pathological, due to some insult which would have happened, the growth is lagging behind, it comes out of the same side. And familial short stature, it is always like this, always it lags behind because of the genetic component. So this is how you distinguish between the three types of short stature. So whenever you find the height velocity normal with the bone age lagging behind the chronological age, the answer is going to be constitutional short stature. And the same scenario, If you find that the height velocity is decreased and the bone age is lacking behind the chronological age, up and answer that is going to be a pathological short stature. So if the height velocity is decreased with the bone age lagging behind the chronological age, the answer is going to be a pathological short stature. So ഇതൊരു മാറ്റി മറിച്ചൊക്കെ സ്ഥിരം ചോദിക്കാറുള്ളതാണ്. You should know to distinguish between the different types of short stature, whether it is familial, constitutional, or a pathological short stature. നേരത്തെ പറഞ്ഞ പോലെ upper segment lower segment ratio. This is also a criteria for short stature. Just remember that in certain conditions like achondroplasia, there will be increased upper segment lower segment ratio. ഇത് ഈ condition മാത്രം achondroplasia മാത്രം മതി നിങ്ങളുടെ ലെവലിൽ. And decreased upper segment lower segment ratio is found in conditions like mucopolysaccharidosis, okay, where the usually the lower segment, where the lower trunk will be much more significant than the upper segment. So ഞാൻ നേരത്തെ പറഞ്ഞ പോലെ there are certain conditions which come under pathological short stature. So basic approach to any short stature is to calculate the mid-parental height. Okay, when you find that the child's age is less than height is less than the third centile, then you have to calculate something called the mid-parental height. So mid-parental height is different for boys and different for girls. For boys, it's going to be the father's height plus mother's height plus 13 by 2. Plus 13 by 2 is going to be the mid-parental height for boys. In girls, it's going to be father's height plus mother's height minus 13 by 2. This 13 by 2 is basically the height velocity difference. Okay. And അതിനുശേഷം ഇപ്പോൾ genetic short stature ആണെങ്കിൽ usually when you calculate, we have to നമ്മൾ growth chart, when you extrapolate the growth chart of the child to the age at 18 years, 18 വയസ്സിൽ extrapolate ചെയ്യുമ്പോൾ it will usually be within the two standard deviations of the mid-parental height is going to be a genetic short stature. At the same time, അങ്ങനെ അല്ലെങ്കിൽ you should see the bone age. നേരത്തെ പറഞ്ഞ പോലെ you should look at the atlas. You should take the wrist X-ray of the child. You should compare it to a standard atlas and you should look at the bone age. If the bone age is delayed, and high velocity is going to be pathological short stature. അതിനകത്ത് വരുന്നതാണ് you can have to go for the upper segment lower segment ratio. Bone age normal ആണെങ്കിൽ you should take the upper segment lower segment ratio. So all these are very complex for you, but just remember that proportional short stature happens in various syndromes. So if they ask you regarding syndromes such as Turner syndrome, dysmorphic syndrome, okay, the bone age will be usually normal because skeletal growth is not affected and the stature will be, that is upper segment and lower segment ratio won't differ. But a normal ratio will be maintained in all main syndromes. At the same time, disproportionate short stature will happen in certain conditions. അതാണ് നമ്മൾ ഈ പറഞ്ഞ ഈ short limbs, increased upper segment ഉള്ള conditions, achondroplasia, decreased will be certain other conditions like mucopolysaccharidosis. Now, where does hypothyroidism, malnutrition, and all fit in? These are also proportionate short stages. The upper segment, lower segment ratio won't differ. The only thing is bone age will be delayed. Okay. In malnutrition, chronic disease, growth hormone deficiency, constitutional delay, the conditions like the short stature is going to be proportionate, which means that the upper segment, lower segment ratio won't differ, but the bone age will be delayed. Okay, these are all pathological short stages. And if it's disproportionate, that is, if you have a condition where the bone age is delayed and there is disproportionate short stature, then that is going to be hypothyroidism or other endocrine disorders in general. Okay, so this is roughly the full graph. You should remember at least where hypothyroidism comes in, where main syndromes comes in, where malnutrition comes in. Okay, all these have to be kept in mind. Come to the next question. A 7-month-old female infant is brought to the pediatric outpatient department by the mother with complaints of chronic diarrhea, irritability, and failure to cry. On examination, dry scale eruptions of the skin is noticed over the perioral and perianal areas, for which micronutrient deficiency is basically implicated in this disease. So this is a classical site. Okay, when you have a description like this, and they've also given an image of a baby with classical perioral eruptions and perianal eruptions, this is indicative of a condition which is called acrodermatitis enteropathica. Classically, an infant or a baby presenting with signs of scaly eruptions over the oral mucosa, especially around the lips and the oral cavity. And when you check the diaper area, there also you can find perianal erythema and skin peeling. That is going to be acrodermatitis enteropathica. And the condition is due to deficiency of a very important micronutrient called zinc. Okay, zinc deficiency will basically cause acrodermatitis enteropathica. So when you come to this context, you should know what are trace elements. So എന്താണ് trace elements? Trace elements are basically elements present in the human body in very small amounts. They are not actually micronutrients also. They are actually less than 0.1% by volume. So if you take the total body volume, എടുക്കുവാണെങ്കിൽ less than 0.1% by composition of elements and trace elements. And the next question is, which is the most common trace element? It is not zinc. Iron is the most common trace element. And you should also notice that calcium is not a trace element, because calcium is something which is present more than 0.1% by volume. So calcium, phosphorus, and all these are all micronutrients, and these are not trace elements. Okay. So what are the common deficiencies which you should know of various trace elements? So copper, copper deficient the children are prone for microcytic anemia, neutropenia, and osteoporosis. Fluoride deficiency can cause caries, especially dental caries and down. Selenium deficiency can cause something called Keshan's cardiomyopathy and Kashin-Beck's disease. Okay, so these two are very important. They have also been asked question. Keshan-Beck's disease and Kashin's cardiomyopathy are associated with selenium deficiency. And chromium deficiency can cause glucose intolerance and neonatal diabetes. Again, a very important question. Zinc deficiency can cause acrodermatitis enteropathica. It can cause hypogonadism, because zinc is a trace element that is required for the normal wound healing. It is required for normal growth of tissues and also for normal functioning. So any deficiency in zinc can lead to hampered wound healing, hampered growth, and hypogonadism. Iron deficiency it can usually lead to hypothyroidism, and manganese deficiency can lead to hypercholesterolemia. So manganese deficiency is something which can cause hypercholesterolemia. This is a table which you should keep in mind. So these are important vitamin deficiencies, and the pictures should be kept in mind. So this is something which is called Casel's necklace. This is seen in deficiency of pellagra. Niacin deficiency or vitamin B3 deficiency causes something called pellagra, where you can find a unique area of scaly hyperpigmented skin which usually spreads around the neck. It hangs down like a necklace. That is why it is called as a Casel's necklace. Okay. So Casel's necklace is found in pellagra. And when you have a question about pellagra due to B3 deficiency, the next thing, what are the classical triads with pellagra? So pellagra typically causes niacin deficiency or acid scan is linked to 3Ds. 3D ആണ് basic characteristics. എന്താണ്? Diarrhea, dementia, and dermatitis. Okay, so this is Casel's necklace. Now we have the next picture. If you notice, you can notice that this child has outstretched fingers. You can notice that there are hypopigmented areas of skin, especially over the knuckle areas. You can notice, I guess. And skin also appears conjum pale. The skin appears a little pale also. So if you notice knuckle hyperpigmentation in a child who suspect to have a vitamin deficiency, it can be a sign of vitamin B12 deficiency. It usually happens in exclusively vegetarian children or adults, because vitamin B12 is a vitamin which is usually present in meat, eggs, and poultry. So it is usually the source of vitamin B12 is very less in vegetarian food. That is why it usually happens in vegetarian people. Okay. And coming to the next picture, it's an easy diagnosis. What is it? So this is the bited spot, which you usually find in vitamin A deficiency, particularly the X1B category. You can find something which is called bited spots. Okay. So again, I'm just going through the other various vitamins and deficiencies. The thiamine B1 deficiency will cause something called beriberi. ഈ ബെറിബറിനെ രണ്ട് രീതിയിൽ വരയ്ക്കണം. Either be a dry beriberi or it can also be a wet beriberi, where a child will present with high output cardiac fever. This will be a classical feature. In dry beriberi, the system which will be particularly affected will be the neurological system. So the classical presentation will be peripheral neuropathy or a loss of vibration and proprioception. So thiamine deficiency causes beriberi. Now riboflavin deficiency can usually cause glossitis. There will be manifestations കുട്ടി വരുന്ന സമയത്ത് നോക്കുമ്പോൾ വായ്ക്കകത്ത് മൊത്തം ചെറിയ പൊള്ളൽ പോലെ മ്യൂക്കോസൽ ഫീലിംഗ് will be there. Glossitis. There can also be corneal vascularization. A very important point, riboflavin deficiency can be caused by phototherapy. Usually phototherapy is the treatment modality which we employ for treatment of babies who have neonatal jaundice. So which vitamin deficiency is usually caused by prolonged phototherapy? Riboflavin deficiency. Riboflavin deficiency can be triggered by phototherapy. Very important. Similarly, raw egg consumption will usually cause biotin deficiency because of a protein called avidin, which is present in throat, which can bind with the biotin vitamins at the GI tract. So that is why raw consumption will lead to biotin deficiency. നേരത്തെ പറഞ്ഞ പോലെ exclusive vegetarian diet, children with exclusive vegetarian diet are very prone to develop vitamin B12 deficiency. And B12 deficiency, other than natural skin manifestation, അല്ലാതെ തന്നെ they can also manifest as something called infantile tremor syndrome, where the child will have early onset tremors. ജനിച്ച ശേഷം ഒരു 3 to 4 months, or 4 to 5 months, they'll usually start having tremors, which usually become generalized. And there is something called subacute combined degeneration because the dorsal tract getting affected. The child will have loss of vibration and they'll have neuropathy. Peripheral neuropathy will also be there. So these are all associated with vitamin B12 deficiency. And then there is something called the burning feet disease, okay, which is associated with vitamin B5, അല്ലെങ്കിൽ pantothenic acid deficiency. So B5 deficiency or pantothenic acid deficiency will lead to something called as the burning feet disease. Okay. So next question note പോവാം. A 6-month-old infant has been brought to the OPD with bleeding spots, anemia, fever, and generalized tenderness. On examination, swelling in both lower extremities were noted and the blood count was normal. So this rules out maybe this is unlikely to be an infection and another what they're meaning. So what is the most likely diagnosis in this case? So they give an osteomyelitis, poliomyelitis, scurvy, and congenital syphilis. So the history is clear. The infant is 6 months old, brought with bleeding spots. So bleeding manifestations predominate. Anemia is there, probably due to bleeding. Like bleeding could have led to anemia. There is fever and generalized tenderness and swelling in both the lower extremities, and the blood count was normal. So basically, an infant with bleeding manifestation, infant or a younger child with bleeding manifestations with swelling is basically due to the bleeding. Okay, the swelling in extremities could probably mean that the bleeding would have led to hemarthrosis, but the blood count was normal, probably ruling out an infection. And in such cases, the most likely diagnosis is going to be scurvy, where the vitamin C deficiency will prominently cause bleeding manifestations. Okay. So again, cow's milk, excessive cow's milk is very, it is not sufficient to, it is not sufficient, does not sufficiently have vitamin C. So exclusive consumption of cow's milk can lead to scurvy. Similarly, where are the question? Exclusive consumption of goat's milk can lead to folate deficiency. So goat ആട്ടിൻപാലിനകത്ത് ഫോളേറ്റിന്റെ അംശം വളരെ കുറവാണ്. So if a child presents with folate deficiency, you should try to elicit a history of consumption of goat milk. And breast milk is rich in all vitamins except vitamin K, vitamin D, and vitamin B. All these three vitamins are not sufficiently found in the breast milk to satisfy the requirements. Okay, that is why after birth you give a stat dose of vitamin K universally for all babies, because vitamin K deficiency vitamin K cannot be depleted by breast milk, and the deficiency can cause bleeding manifestations. Vitamin D, usually vitamin D is also supplement which we start for newborn babies because it is usually not present in breast milk. And B complex, as I told earlier, is a vitamin which has to be supplemented. Okay. So scurvy പറ്റി പറയുമ്പോൾ scurvy is a disease which has predominantly bleeding manifestation. Why does this bleeding manifestation happen? Vitamin C is very important for vascularization. It is very important for the formation of the blood vessels, for the laying down of the collagen and cartilage. So collagen, for the formation of collagen, vitamin C is very important, and collagen forms the framework of the vascular system which we have. So when the collagen bonds are not adequately formed, it can lead to weak blood vessels and which can easily bleed. That is why scurvy, the predominant manifestation of scurvy is going to be, sometimes you'll find oral bleeds, mucosal bleeds. So bleeding is going to be the predominant manifestation in scurvy. So suppose they give a similar history of a child who presents to the OPD with frequent episodes of oral bleed or gum bleed and similar condition, you should also think about scurvy. Scurvy, the thing should come in your mind first. Okay. So in scurvy, you have certain peculiar radiological findings which are also asked time and time in various entrance exams. So if they give you an X-ray like this and ask you to identify what the disease is, it is going to be scurvy. So what are the classical radiological signs in a typical scurvy? Usually, because of the microvessel bleeding, along the sign of the provisional calcification, along the sign of along the epiphysis, there will be a white ring. This white ring is probably due to microbleeding. Okay, micro trauma bleeding white halo like thing is called the Wimberger's ring. So this, if you see an X-ray around the epiphysis, you find there is a white small lining. This is going to be scurvy. This is called the Wimberger's ring. Similarly, at the metaphyseal end of the bones, due to repeated trauma and healing, there will be spur-like formation, which is called Pelkin spur. So if you find typical spurry at the metaphysis, called Pelkin spur, and അതിനുശേഷം due to this trauma, there will be the body will try to compensate it by trying to calcify. So you can also find something like a dense zone of provisional calcium. താഴെ കാണുന്നത് ഒരു ചെറിയ calcifying zone. So this is called the dense zone of provisional calcification, and it is also called as the line of Frankel. So the line of Frankel, the Pelkin spur or the metaphyseal spurs and the ring epiphysis are classical radiological findings in scurvy. So X-ray തന്നിട്ട് if you find an epiphyseal structure with a white lining around it and you find the spur, it is inevitably it is going to be scurvy. Okay. Next question: a 2-year-old male child presents in the OPD with manifestations of wide-based unsteady gait and vision difficulty with limited upward gaze. Okay, and the examination reveals absent deep tendon reflexes and diminished proprioceptive and vibratory sensations in the child. So deficiency of which vitamin will most likely cause such manifestations? Okay, so ഹിസ്റ്ററി ക്ലിയർ ആണ്. ഇപ്പൊ ക്വസ്റ്റ്യൻ നമ്മൾ നോക്കിക്കഴിഞ്ഞാൽ അവർ ചില കാര്യങ്ങൾ എടുത്തു പറഞ്ഞിട്ടുണ്ട്. The child has absent DTR and they also have diminished proprioceptive and vibratory sensations. So ഞാൻ നേരത്തെ പറഞ്ഞു diminished vibratory sensation, proprioceptive sensation can happen in B6 deficiency, B12 deficiency and vitamin E deficiency as well, because all of these can affect the dorsal column pathway. Okay, but there's a catch. So B6 is pyridoxine. Pyridoxine deficiency can also cause peripheral neuropathy. So there's a catch in this. They have mentioned wide-based unsteady gait. Okay, so if you have a scenario where the child has typically a dorsal column pathway being affected with a gait being unsteady, it typically happens due to deficiency of vitamin E. Where over vitamin deficiency, the gait usually won't be wide and steady. So, and vision difficulty can happen vitamin A deficiency as well, but the limited upward gaze is also featured at the vision center is affected. This is also a sign of vitamin E deficiency. So in vitamin E deficiency, there will be a lack of DTR, the lack of vibrator sensation, and there also will be a gait abnormality, which can lead to all the neurological manifestations. So this was a question which was asked in NEET PG 3 years back. So that is why vitamin E deficiency is the answer. Now going to the next topic, sutures. Among the cranial suture, which is the earliest cranial suture? This is also a repeatedly asked question. Which is the earliest cranial suture to fuse? So to understand this, you should know this diagram. So what are the cranial sutures? What you can, if you can notice that you can distinguish the sutural separations. You can, after some time, they start fusing and they start fusing together. But at the time of birth, this is how the baby or the infant skull will look like. You have a suture called the metopic suture, which starts from the forehead, extends downward, and then there is this thing which is called the anterior fontanelle. This is called the AF, which usually closes, and the AF has a boundary line by the metopic suture. Then the side there are sutures called the coronal suture because it cuts through coronally. This is the coronal, this is the sagittal, right? So since the suture cuts through coronally, it is called the coronal suture on either side. So this is the left coronal and this is the right coronal suture, and you also have something called the sagittal suture. So the AF is bound by the metopic suture, the sagittal suture, the coronal suture on either sides. And when you come down, there is a suture here which is called as the lambdoid suture, and the occipital bone is there. So this is how the sutures look like in a baby's or an infant's skull. So among these, the earliest to fuse will be the metopic suture. The metopic suture will fuse at the age of around 2 to 3 months, and after that, the sagittal and the coronal sutures fuse very late. They usually fuse at around 2 to 2.5 years, around 24 to 26 months. So sagittal sutures, coronal and lambdoid sutures will fuse at around 2 to 2.5 years. 2 to 2.5 സമയത്ത് മാത്രമേ ഇത് ഫ്യൂസ് ആവൂ. So metopic suture fuses as early as 2 months. And then, but these are not the last sutures to fuse. നമ്മൾ കാണിക്കാത്ത കുറെ sutures ഉണ്ട്. അത് ബേബിയുടെ മുഖത്തിന്റെ frontal ഭാഗത്ത് there are sutures called frontonasal and frontozygomatic sutures, and these are the last sutures to close. They close by the age of 68 to 72 months. They usually close by the age of 68 to 72 months. So frontonasal and frontozygomatic sutures are typically the last sutures to close. Okay. Now, based on this, you can also identify what are the defects associated with sutural closure. Okay. So if a metopic suture happens here, right? So any premature fusion of suture is what is called craniosynostosis. Again, a very important question. So what is a craniosynostosis? If a sutural fusion happens premature to the age at which it is supposed to close, this is called a craniosynostosis. So if the metopic suture closes early, what will happen? If it closes early, what will happen? The bones will be elongated in a triangular fashion. This is called trigonocephaly. And the front the triangular that is called trigonocephaly because the metopic suture fuses predominantly early, because of which the frontal area will be, the bones will fuse in a triangular fashion. This is called trigonocephaly. This happens due to premature fusion of the metopic suture. Now coming to brachycephaly. Brachycephaly is also called as flat skull, which happens due to premature fusion of the coronal suture. So coronal suture fuse the bones will be kind of flat here. So the fusion will happen such a way that it will be flat. So this will lead to this appearance of the skull, and this is called a brachycephaly or a flat skull. And if coronal suture can also fuse unilaterally. Because suppose if it fuses unilaterally, then it will be something called as a anterior plagiocephaly, which means one side will be distorted and the other side will be normal. This is called as an anterior plagiocephaly. This is a left anterior plagiocephaly. Notice you can see that the left coronal suture has fused early compared to the right coronal suture. And scaphocephaly is due to premature fusion of a sagittal suture, and this is the most common type of craniosynostosis. കൂട്ടത്തിൽ ഏറ്റവും വലുത് sagittal suture ആണ്. So premature fusion of sagittal suture will lead to scaphocephaly, and this is also the most common type of craniosynostosis. And you find something called as a boat shaped, ഒരു വഞ്ചി പോലെ ഇരിക്കും, വള്ളം പോലെ ഇരിക്കുന്ന skull is the classical feature of scaphocephaly due to predominantly early fusion of the sagittal suture. And then you can also have posterior plagiocephaly. This happens due to early fusion of the lambdoid suture. Lambdoid suture will lead to posterior plagiocephaly, where the deformity will be predominantly unilateral to one side. And sometimes the children can also have something called as deformation plagiocephaly. So in the deformation plagiocephaly, they can have positional skull flattening. If one position, if the children are made to lie down, there can be a positional flattening. അങ്ങനെയുള്ള പൊസിഷണൽ ഫ്ലാറ്റനിങ്ങിനെയാണ് നമ്മൾ deformation plagiocephaly എന്ന് വിളിക്കുന്നത്. Okay. So these are the important type of craniosynostosis which you'll have to keep in mind. Next question, we'll go to development. A normal infant sits briefly, leaning forward on her hands, reaches forth and grasps a cube and transfers it from hand to hand. She can babble but cannot wave bye-bye, nor can she grasp objects with the finger and thumb. What is her age? Again, whenever you get a question based on development, you'll have to go through the key points and you should know what age the already given milestones have been attained. I mean, Aranyam, it is very simple. Okay, so what age it is. So you can notice that the infant sits briefly leaning forward on her hands and reaches for and grasps a cube. Usually, an infant or a baby is able to reach for and hold an object by 4 to 5 months of life. So you are sure that this infant would have crossed 4 to 5 months of life and can transfer it from hand to hand, which means the infant has something called as a unidextrous grasp and bidextrous transfer. That is, from one hand, the infant is able to transfer the object to the other hand. This is called as a bidextrous transfer, which again happens by around 5 to 6 months of age. He is able to babble. So babbling is also something which happens at 5 to 6 months of age, but she cannot wave bye-bye. This is the catch. Nor can she grasp objects with the finger and the thumb. Okay. So bye-bye or saying tata, bye-bye the developmental milestone usually is attained by what age? 9 months of age. Bye-bye is attained by 9 months of age. And this grasping objects with the finger and thumb, this is called pincer grasp. Okay, this is very important. This is called pincer grasp, approximating objects between the finger and the thumb. നമ്മുടെ ചൂണ്ടുവിരലിന്റെയും തള്ളവിരലിന്റെയും ഇടയിൽ കുട്ടികൾ objects എടുക്കുന്നതിനെയാണ് pincer grasp എന്ന് പറയുന്നത്. And this usually starts by 9 months of age, where they'll have an immature pincer grasp and it becomes mature by the age of 1 year. So from this question, it is obvious that the child cannot wave bye-bye and neither has pincer grasp. Another 9 months, the child is definitely more than 5 to 6 months, but has not attained 9 months. So which means what is the age from this category? It is not 4 months, it is not 10 months, because child cannot wave bye-bye or pincer grasp is not there. The answer is going to be 7 months. Okay. നേരത്തെ പറഞ്ഞ പോലെ, so by 9 months, child will have immature pincer grasp and is able to say bye bye. And by language, they should also say bisyllables, mama, dada, and they'll also stand with support. So before developmental milestones is a must, it is just a must for any entrance exam. നമ്മുടെ ഏത് എക്സാമിന് if you are going to prepare, and pediatrics, if there's some questions which we are definitely 100% sure of, it is going to be from developmental milestone. You can expect minimum 2 to 3 questions. So at least OP Gaila table on the basic milestones, you should be well versed and familiar with developmental milestones. The weightage for developmental milestones is 100%. Any entrance exam will always, they will not conduct an exam without asking developmental milestones. So that is the importance of this topic. So because just I'm giving a reference question, you should all be familiar with all the important milestones which are attained at all the current age groups. So this is the pincer grasp, where you can see this, that the child is able to pick things up, usually approximate objects between the index finger and the thumb. This is immature. So immature pincer grasp happens by 9 months, where they will not be able to approximate exactly correct point. They'll be able to hold it like radially or kind of like on the radial aspect. But if they're able to point it exactly like this, it will happen to this mature pincer grasp, which happens at 1 year of age. Okay. So next question about development. A child has a vocabulary of 4 to 6 words. However, the main mode of communication and social interaction continues to be non-verbal. Okay. So they have given a question here. So the vocabulary again, what is the vocabulary? 4 to 6 words. So usually by the age of 1 year, child will be able to say around 3 to 4 words. But again, after 1.5 years, the child will have a main mode of communication will usually be verbal. So this, which means that the main mode of communication and social interaction is non-verbal. It means that it is something called as jargon speech. Jargon speech is something where the child will try to utter words. It will not be verbal. That will not come out to be, it will not be having any meaning, but it will be a mode of communication for the child. They'll utter words which only they know and which only they can decipher. So that will be their main mode of communication, and this is called as jargon speech. So with a vocabulary of 4 to 6 words and setting in of jargon speech, the child's development age is going to be 15 months, because jargon speech usually sets in by the age of 15 months. This is also a repetitively asked question. When does child attain jargon speech? The answer is 15 months. Next question. A child walks up and down stairs, is able to put 2 feet per step, builds a tower of 8 cubes, tells I but not his name, and cannot say his age and sex. Again, the catch is in the question itself. ചൈൽഡ് ഇങ്ങനത്തെ കുറെ കാര്യങ്ങൾ ചെയ്യുന്നുണ്ട്, പക്ഷെ ഒരു കാര്യം മാത്രം ചെയ്യാൻ പറ്റുന്നില്ല. യൂഷ്വലി he is not able to say his name and cannot say his age and sex, but he is able to tell I. So ബാക്കി ഒന്നും കണ്ടില്ലെങ്കിൽ ഇതിൽ തന്നെ നമുക്ക് ആൻസർ കിട്ടും. So usually the sense of pronoun, okay, a child is able to say I, we. The sense of pronoun usually happens by the age of 2.5 years. And the child will usually able to identify himself or herself by his or her name, will be able to tell his or her age and sex by the age of 3 years. So if a child can say pronouns but cannot say his name, age, and sex, the child's age will be definitely around 2.5 years, but not 3 years. So what will be the answer to this question? It is going to be 2.5 years. Again, they've also given two other things: walks up and down stairs. So usually by the age of 2 years, a child will be able to walk up and down stairs with 2 feet per step. And once they have gone to 3 years, they will be able to walk up with 1 feet per step. And by 2 years, a tower of 6 blocks, R block and a tower, they'll be able to build, and they'll also be starting to recite sentences. They will be able to speak in small, small sentences. This all happens by the age of 2 years. And what happens by 3 years? Again, very important. They will ride a tricycle, alternate feet going upstairs. നമ്മൾ നേരത്തെ ഇവിടെ പറഞ്ഞു, 2 years, 2 feet will go up and down. They'll be able to navigate up and down with 2 feet. But if alternate feet is going upstairs, that is a sign of a child having attained 3 years of age. And if 2 years child is able to build 6 blocks, at 3 years the child will be able to build 9 blocks, and the child will be able to copy a circle. And again, will be knowing his or her name and gender by the age of 3 years. Okay, so this is a അതേപോലെ this is the diagram which I've exactly taken from OPK. അതേപോലെ എടുത്ത പടമാണ്. So you have to notice that by the age of 2 years, the child will usually will start building a train. They'll start building a train by the age of 2 years, and usually by 4 years, it will progress to a bridge with only 3 blocks. By 5 years, they'll build a gate, and by 6 years, they'll be able to build a step. Okay, this is also just remember it in a progressive fashion. Train with chimney, a bridge, and a gate from 2.5, 4 to 5 years. And usually by 3 years, I told you that by 2 years, they'll build a block of six, they'll build a tower of 6 blocks. By 3 years, they will be able to build a tower of 9 blocks. So this is how development progresses when it comes to building blocks. Next question. A 6-year-old child was evaluated in the OPD and was found to have a developmental quotient of 50. Which of the following do you think this child will do? Okay. So again, question, they have given something called as a developmental quotient. So to answer this question, you should know what is DQ or developmental quotient and what that means with respect to the developmental age of the child. So developmental quotient basically means that it is the developmental age by chronological age into 100. അതായത് developmental quotient of 50, which means the developmental age of the child will be 3. അതായത് 6-year-old child, this is the chronological age of the child എന്തായിരിക്കും 6 വയസ്സാണെങ്കിൽ developmental quotient 50 ആണെങ്കിൽ, which means the child will be having a developmental age of 3 years, which means the child is doing developmental milestones which is expected only for the age of 3 years. അതായത് 6 വയസ്സായിട്ടും 3 വയസ്സായവന്റെ developmental maturity ആ കുട്ടിക്കുള്ളൂ. So DQ basically means the developmental age by chronological age into 100. So if the DQ is more than 85, it means it is normal. So normally, if it is more than 85, it is normal. And if it is less than 70, it is abnormal. And 70 to 85 is a close gray area which warrants follow-up. But any DQ less than 7 is abnormal. So this DQ 50 is very abnormal. So now coming back to the question. The 6-year-old child ആണ് അവന്റെ DQ was 50, which means that 50 is equal to developmental age by chronological age. So obviously the developmental age is going to be 3 years if you do the calculation. അല്ലെങ്കിൽ കൂടെ നേർപകുതി DQ is 50, which means it is going to be the half. So 3 വയസ്സിന്റെ developmental maturity ആൾക്കുള്ളൂ. അങ്ങനെയാണെങ്കിൽ what will the child do? Will the child skip with both feet? No. Skipping rope will usually happen by 4 to 5 years, so that is wrong. The child will not do that. Copy is a triangle again. It happens by 5 years of developmental age, so this is not going to happen. Can identify name colors? Yes, it is possible. In നേരത്തെ പറഞ്ഞു 3 വയസ്സായി കഴിഞ്ഞാൽ they can identify, they can name colors, they can name themselves. So this is possible at 3 years of age. Will dress and undress himself without supervision is also wrong because this happens at 5 years of developmental age. മനസ്സിലായില്ലേ? So ഇപ്പൊ ഈ നോർമലി ഒരു 6 വയസ്സ് കുട്ടിയായിരുന്നെങ്കിൽ ഈ പറയുന്ന 4 കാര്യങ്ങളും ചെയ്തേനെ. That is the catch. But for a child who has a DQ of 50 with and the age of 6-year-old, they are expected only to do developmental milestone of a 3-year-old. So the answer is going to be can identify and name colors because all the other 3 will usually happen by 4 to 5 years of age, especially the 5 years. So this is something which we all find difficult to memorize. Circle 3 years, 4 years, 4.5. It is very difficult to memorize. This was how we all learned how to memorize this. So this is a like kind of a pick art kind of thing. ഇതൊക്കെ ഞങ്ങൾ യൂസ് ചെയ്യുന്ന സമയത്തുള്ള ഒരു സാധനമാണ്. It's like a പൊടിക്കൈ. So basically, you just have to remember this man's figure, and you have to draw this figure from head to toe, and based on that, you can just identify the time frame. So if the first at around 18 months, a child will be able to draw a vertical line at the age of 18 months. So തൊപ്പിയുടെ ആദ്യത്തെ ഭാഗം, and then the child will be able to draw a horizontal line at the age of 24 months. അടുത്ത വരുന്നതാണ് തല. തല is a circle which happens by the age of 3 years. And by the age of 4 years, the child will be able to draw a square, a rectangle, or a cross. The plus sign or the rectangle or a square will happen by 4 years. And by the age of 5 years, the child will be able to draw a triangle. And by the age of 6 to 7 years, the child will be able to draw a diamond, and by 9 years they will be able to draw a cylinder. So this is something which is very easy to remember. ഇങ്ങനെ ഓർത്ത് കഴിഞ്ഞാൽ otherwise it's going to be a huge mugging up thing because it's very difficult to memorize this. അല്ലെങ്കിൽ 3 വയസ്സ് 4 വയസ്സ് 4.5 വയസ്സ്. So it's better to remember like this, where 3 years you'll have a circle, the body will be 4 years, 5 years a triangle, 6 to 7 years is going to be a diamond shape, and 9 years the cylinder. And by 11 years, that will also be able to draw a cube. Okay. So just keep in mind this picture. We'll go to the next question. So there are some things which are called as red flag signs. Red flag signs basically means that the child will be not, if a child is not able to attain this milestone by this particular age, then that is a red flag. We usually expect this to happen within this particular time frame, but that doesn't happen, which means that the child is having some problem probably. So these are called red flag signs. And when it comes to red flag sign, you should remember that visual fixation is something which should happen by 2 months of age. If a child is not able to attain visual fixation by 2 months of age, that is definitely abnormal. Adebole vocalization, if it doesn't happen by 6 months, it is abnormal. Sitting without support, you should normally start by the age of 8 to 9 months. And if it doesn't start by 10 months, it is a red flag sign. Standing with support usually happens by 10 months. If it doesn't happen by 12 months, it is a red flag sign. So like that, we can remember that there are certain red flag signs for everything. Okay. Next question. A 2-year-old girl child comes to the OPD with features of hand wringing stereotype movements, impaired language and communication development, breath holding spells, poor social skills, and deceleration of head growth after 6 months of age. This is a trivial question. Okay, this is basically based on the clinical characteristics of a particular disease. And they have given a lot of description, but if you notice a particular thing which is a standout catch of this question, it is hand wringing stereotypic movements. So, girl child who's having repetitive wringing movements with otherwise an issue of a neuroregression or impaired social skills, deceleration of head growth and breath holding spells, the most likely diagnosis is going to be something called as Rett syndrome. This is also a question which has been asked over and over in multiple entrance exams. ഞാൻ പഠിക്കുന്ന സമയത്ത് തൊട്ടേ ഉള്ള question ആണ്. It has been asked continuously every 2 3. I think the examiners are very fond of this syndrome, Rett syndrome. Just remember that if the mode of inheritance of this is going to be X-linked dominant. So Rett syndrome is usually inherited in X-linked dominant fashion, which means only girls will have this disease, and they'll present with hand wringing stereotypical movements and impairment in communication and social skills. Next question. So what was the order of development of secondary sexual characteristics in a male? I think you are already familiar with this. Usually, testicular development is the first stage. Okay, testicular development happens always first, and then the pubical hair develops, axillary hair develops, and the beard usually forms last. Okay, so if you're asked to state the order, it is going to be testicular development, which gives way to pubic hair, to the axillary hair, and beard, because these are secondary sexual characteristics which only form after the primary sexual characteristics are properly formed. So the answer is going to be A, where testicular development, pubical hair, axillary hair, and beard. So earliest change in testicular size where the volume reaches by around 4 ml or 2.5 centimeters in length, and this usually happens between the age of 9 to 14 years. After which pubic hair appears and the penis starts lengthening. So this is between 9 to 14 years. The first appearance of secondary testicular development happens between 9 to 14 years. So this is again very important when you remember the onset of secondary sexual characteristics, which is called as the SMR staging or the Tanner staging. So ഇതിൽ പ്രത്യേകം ഓർത്തിരിക്കേണ്ട കാര്യം the maximum growth velocity. This is another favorite question. They are going to ask you in which Tanner stage is the maximum growth velocity going to happen. Okay, the maximum growth velocity in boys is going to happen between stages 4 to 5. But if you're asked to pick one stage, it is going to be stage 4. So in Tanner stage 4, the growth velocity is going to be the peak, or in the maximum growth velocity in boys is attained during SMR stage 4 or Tanner stage 4. So basically, this stage grades the appearance of secondary sexual characteristics from 1 to 5, where 1 is pre-pubertal. testicular volume will be less than 3 ml, and till the stage 5, a testicular volume will be the adult size, which is 25 ml, and they'll have adult hair which spreads to the medial thighs. Okay. Similarly, when you come to the girls, the maximum growth velocity happens in stage 3, where there is a difference between the peak growth velocity attainment SMR in girls and boys. Boys in it is between stage 4 to stage 5, but if you're asked to state a single stage, it is going to be SMR stage 4. Similarly, in girls, it is going to be SMR stage 3, which means before attainment of menarche. Okay, that is stage 3. And in girls, again, it is graded from 1 to 5. And again, the same thing is going to happen. 1 is pre-pubertal with no hair, and 5 is when the adult breast is formed. But again, there is second thing, something to note. There's something is called secondary mount. Okay, secondary mount എന്ന് പറയുന്നത് the nipple and areola along with the breast they'll form a secondary mount alongside. So this is called the secondary mount, and this usually happens in SMR stage 4, and hair increase will also happen. So there are potential questions in this grading as well. So when is the peak growth velocity attained in girls? It is stage 3. At which stage is secondary mount formed? It is stage 4, and pivotal stage is stage 1. Okay, so SMR staging is also something which you should try to memorize before you go for the exam. So peak growth velocity in adolescent girl happens at the time of stage 3, which happens just before the commencement of menarche. Okay, coming back to nutrition. Which of the following parameters is the best indicator of long-term nutritional status? Is it metaparam circumference? Is it height for age? Is it weight for age? Or is it weight for height? You have to notice that metaparam circumference is a criteria for defining severe acute malnutrition. So it is definitely a criteria for acute malnutrition, which means it is a criteria for short-term nutritional status. It is not chronic. Weight for age is underweight. So weight for age is called, if it is decreased, it is called underweight. And weight for age, decreased weight for height is called wasting. Okay. So decreased weight for height is called wasting. Decreased weight for age is called underweight. Both of these are parameters for measuring acute malnutrition. They are indicators of short-term nutritional status. Height for age is something which is called as stunting. So decreased height for age is called stunting, and stunting is an indicator of chronic malnutrition because height is usually affected at the end. Acute malnutrition usually reflects on the weight, reflects on the weight. But if height for age is affected, it means that it is a chronic malnutrition, and stunting stunting that basically means decreased height for age. So stunting is an indicator of chronic malnutrition. All the other three are indicators of acute malnutrition. As I've mentioned, weight for height or wasting is an indicator of acute malnutrition. Next question. Weight of a child is 70% of normal. According to IAP classification of malnutrition, child is categorized as. ഇത് അറിയണമെങ്കിൽ നമ്മൾ ഈ ക്ലാസിഫിക്കേഷൻ മൊത്തം പഠിക്കണം. സോ അതും വേറെ നിവൃത്തിയില്ല. There are some 3 classifications which you'll have to memorize. The Waterloo's classification, the IAP's classification, and there is also something called as the Gomez classification. You should at least know what each classification, the basic cutoffs are there in each. And there is also something which is called very important, the Wellcome Trust classification, which defines kwashiorkor and marasmus. We'll come to that later. So IAP classification, basically, it is based on the weight for age. Okay. So if it is more than 80%, it is normal. It is basically purely a trivial question. You have to learn this. There's no other option but to by heart this. But just remember that if it is more than 80%, it is normal. So anything which fits between 71 to 80, 61 to 70. So it happens in increments of 10 from 50, 10, 10, 10, 10. Like that it goes. So 71 to 80 will come in grade 1. But if it is 70%, you should know that it comes in grade 2. Okay. So it is not 70 to 80%, it's 71 to 80%. That is the catch here. If weight of a child is 70% of normal, it falls in grade 2 malnutrition and not in grade 1 malnutrition. It is not 70 to 80, it is 71 to 80. So usually grade 2 malnutrition is something which is called as moderate malnutrition. So mild, moderate, and anything less than 50 is severe malnutrition. So this is the other classification, which is called the Gomez classification, which is also based on the weight for age. So Gomez classification, IAP, if it is more than 80, it was normal. Gomez classification defines weight by age more than 90 as normal and less than 60 as severe malnutrition or third degree malnutrition. So IAP defines 80 and 50 as the upper and lower limit. Gomez describes 90 and 60 as the upper and lower limits, and it happens in increments of 15. So IAP had 4 degrees. If you notice, grade normal 1, 2, 3, 4, but Gomez has only 3 grades of malnutrition. This is a very important classification, Waterloo's classification. Waterloo had basically defined classification for stunting as well as wasting. What is stunting? Classification of height for age is called stunting, and what is wasting? Weight for height, decreased weight for height is called wasting. So Waterloo made separate classification for both stunting and wasting and put together as a single classification. Okay, so what are the classification for stunting? Usually, if it is more than 95%, so you have a child whose height for it is more than 95% of the normal, 95% of the growth chart, that is going to be normal. And 90 to 95 is first degree stunting or mild stunting, 85 to 90% is second degree stunting or moderate stunting, and anything less than, it is not more than, anything less than 85% is third degree stunting or a severe stunting. So, which means that the malnutrition is chronic. So, stunting is an indicator of chronic malnutrition. So, any the depiction of height for age, it means that it is an indicator of a chronic malnutrition. And if it is less than 85%, it means that it is a third degree stunting or a severe stunting. And similarly, we have a classification for wasting as well. Waterloo തന്നെ കൊടുത്ത വേറെ classification is for weight for height. This is the classification of wasting. For stunting, it is 95%, which is normal. In wasting, if you find that if it is more than 90%, it is normal. And if it is less than 70%, it is third degree wasting, or it is also called as severe wasting. Okay. So you should remember this classification. This is also frequently asked question when it comes to MCQs. So more than 90%, less than 70%, even more than 95%, less than 85%. So wasting is a marker of acute malnutrition, and stunting is a marker of chronic malnutrition. So Waterloo's classification of malnutrition takes into account what? A, weight for height, B, height for age, C, weight for height and height for age, and D, weight for age. So answer is going to be C. He has included both weight for height and height for age in classifying malnutrition. Next question, again a very important topic. Which of the following is classically seen in marasmus and not in kwashiorkor? A, voracious appetite, B, fatty change in liver, C, hypoalbuminemia, and D is edema. So to know this, we should first know how to define marasmus and how to define kwashiorkor. So there is this classification which is particularly very important from MCQ point of view. The classification is called the Wellcome Trust classification. So the Wellcome Trust classification is based on weight for age, and this classification distinguishes between kwashiorkor and marasmus. So when you have a child with 60 to 80% of the corresponding reference weight for age and the presence of edema, to define that the baby or the child has kwashiorkor. So 60 to 80% weight for age with edema is what we call as kwashiorkor. Akshay, the same 60 to 80% weight for age with no edema is just underweight. You understand the difference? No. So if a child has the same 60 to 80% reference weight with edema, it is kwashiorkor. Without edema, it is underweight. And less than 60% weight for age without edema is called marasmus. So marasmus, from this you understand that marasmus will have severe decrease in weight for age, and the child will usually not have edema. So kwashiorkor's hallmark feature is edema. Marasmus hallmark features decreased weight for age, significantly decreased weight for age, but with no edema. Now, if a child has both, has 60% weight for age with the presence of edema, it is an entity called marasmic kwashiorkor, which is often described as a mix of both marasmus and kwashiorkor. So, നമുക്ക് ഇതിന് എന്ത് മനസ്സിലായി? Classically, kwashiorkor will have edema. Classically, marasmus will not have edema, but they will have less than 60% weight for age. And so this is how they appear. See, if you notice that the kwashiorkor baby appears until it looks like baby is very edematous, looks like an ascites, baby looks very puffed up. So this is how a baby of kwashiorkor, although they have an acute malnutrition, will look. While marasmus, if you see, this was an old man appearance. Under monkey face appearance, but this is now described as an old man appearance. Under same also. You can see the ribs protruding, the skin is very pale, brittle, and The child is very malnourished. You can understand there's no edema. So this is how a typical description of marasmus is. And this is how you describe a kwashiorkor. Okay. So how to distinguish? So marasmus, there will be significant wasting. If you notice significant wasting, the child has significant wasting of fat, subcutaneous tissue, everything. So that is why significant wasting. But in kwashiorkor, this wasting is hidden. Why? This wasting is hidden because of the obvious edema. For sure, the wasting definitely happens, but this wasting is hidden by the edematous appearance of the child. So that is why it is hidden. And edema is again a classical feature of kwashiorkor. And one very important thing is kwashiorkor children will be irritable. They will have mental changes at the early onset. They will be irritable and apathetic, while this is a late feature when it comes to marasmus. And marasmus children will have a very good appetite. Kwashiorkor will have a poor appetite. Okay, very important. Marasmus babies will have an appetite which is usually described as a voracious appetite. വളരെ വൊറേഷ്യസ് മീൻസ് സിഗ്നിഫിക്കൻലി ഇൻക്രീസ്ഡ് അപ്പറ്റൈറ്റ് അങ്ങനെ ആർത്തിയോടെ ഭക്ഷണം കഴിക്കുന്ന ഒരു അവസ്ഥയാണ് വൊറേഷ്യസ് അപ്പറ്റൈറ്റ്. So voracious appetite is a classical description of marasmus, but kwashiorkor children usually will have a very poor appetite, but they can have mental changes. Okay, and they will usually have hair and skin changes. Kwashiorkor will typically have hair and skin changes, which we usually describe as flaky paint dermatosis. The kwashiorkor children will have this thing which is called flaky paint dermatosis, where the skin starts peeling off in segments. Paint that is called flaky paint dermatosis, which is a classical feature of kwashiorkor. And they also have something which is called as the flag sign, where they'll have alternate pigmented and depigmented hair because of kwashiorkor is basically protein deficiency. So melanin is responsible for pigmentation of the skin and the hair. So basically, kwashiorkor melanin production കുറയുന്ന കാരണം ഉണ്ടാവുന്ന pigmentation issues കാരണം they can have alternate pigmented and depigmented hair. So this is called flag sign. So which acute malnutrition or protein energy malnutrition is associated with flag sign and flaky paint dermatosis? It happens in kwashiorkor. So from this classification, you can understand that kwashiorkor will typically have diffuse skin manifestations, while marasmus will usually not have will usually won't have skin changes. Again, next important thing is hepatomegaly. Liver enlargement is a classical feature of kwashiorkor because the liver usually the liver is bringing protein source ഉണ്ടാവുന്നത്. So lipoproteins, everything will produce. So liver will try to compensate it by trying to increase the protein production. Because of this hypertrophy, kwashiorkor will have fatty liver. Marasmus babies won't have a hepatomegaly as such. So if we come back to the question, which of the following is classically seen in marasmus and not in kwashiorkor? Fatty stage in liver. It happens exclusively in kwashiorkor, but marasmus usually won't be there. Protein deficiency. Hypoalbuminemia is a classical feature of kwashiorkor, which leads to edema. So all these three are features of kwashiorkor, but voracious appetite is a classical feature of marasmus. So marasmus is going to be the answer in this question. I hope it is clear. And then there is a separate category of breeding for severity for marasmus and kwashiorkor. Basically, you define marasmus based on the wasting, the extent of wasting. As I told, marasmus is typically characterized by a significant wasting, weight for age less than 60%. So they will have initially loose skin folds of axil and growing and wasting of thigh and buttock stage 2. Initially, on the back in pronunciation, it goes to chest and back to the stage 3. And wasting of buccal fat. The buccal fat is a rich source of fat. Okay. So the wasting of this buccal pad of fat usually happens at the end. So if you have a child who you suspect to have protein energy malnutrition and they have buccal pad of fat being lost, that is going to be very severe marasmus because stage 4 marasmus will be having buccal pad of fat being lost. അതേപോലെ kwashiorkor, if a child has ascites, that is going to be severe kwashiorkor, that is grade 4 kwashiorkor. Pudendal edema is grade 1, facial edema is grade 2, chest and body edema is grade 3. But if you have a child of kwashiorkor with ascites, that is going to be very severe kwashiorkor. I hope it is clear. Next question, a 2-year-old girl presented with this deformity. So this is the deformity. This investigations revealed serum calcium as 9 milligrams per deciliter, phosphate to be 2 milligrams per deciliter, alkaline phosphate is 1041, normal intact parathyroid hormone, and bicarbonate is 22 millicoulombs per liter. So which of the following is the most probable diagnosis? The first നമ്മൾ നോക്കേണ്ട പടത്തിലാണ്. So what does the child in this picture have? Like what is this condition called? It is called wind-swept deformity. It is called wind-swept deformity, or in other context we also define it as something called genu valgum. Valgum means approximation, vara means away. So this is called genu valgum. The child has genu valgum, and probably this can be a sign of something called rickets. This can be indicative of something called rickets in the child. So ഈ rickets in the description വേണ്ടി they have given further parameters. Serum calcium they given us 9 milligrams per deciliter. So the normal serum calcium range is 8 to 10. So this is normal. So serum calcium normal. Phosphate is 2 milligrams per deciliter. So normal phosphate level in a child is somewhere between 4.5 to 6.5, which means that the phosphate level is slightly reduced. It is reduced actually. ALP is elevated and parathyroid hormone is normal. Bicarb is also normal. So നമുക്ക് എത്ര കാര്യങ്ങളുണ്ട്? Calcium is normal. Bicarb is normal. PTH is normal. And they're asking which of this is the most probable diagnosis. So rickets is basically of two types. We have the standard nutritional rickets. The vitamin D deficiency rickets is there. So the vitamin D could respond. So vitamin D deficiency rickets will usually have decreased calcium and increased PTH. So any vitamin D deficiency rickets will have decreased calcium because vitamin D is responsible for absorption of calcium from the intestines, from the bones, and if vitamin D is deficient, what will happen? The parathyroid hormone levels in the body will compensatorily go up. So PTH levels will be high and calcium will be low. So this is a picture of vitamin D deficiency rickets, which is a normal type of rickets which we encounter. But there are some things which is called refractory rickets, which means നമ്മൾ vitamin D ഒരു course കൊടുത്താലും they may not respond. So for this, you should know how to approach a refractory rickets. There are certain causes for refractory rickets. Okay. If a child has features of refractory rickets or refractory bond features, the first thing you should do is to measure the serum phosphate level. Serum phosphate level high with rickets, there is only going to be one single diagnosis, that is chronic kidney disease or a chronic renal failure. Because the kidney is finding it difficult to excrete phosphate out from the kidney, the baby will have extremely high phosphate with refractory rickets. So there is only one clinical condition where rickets is possible with high phosphate level, that is going to be chronic kidney disease. ഇനി phosphate നമ്മൾ measure ചെയ്തു. It is either low or either normal. അങ്ങനെയാണ് condition. The next step is you have to go for a blood gas to see the acidity of the blood. Okay. And if you find that the blood pH is low, that is a condition called renal tubular acidosis. So the again only condition where the rickets will cause an acidotic pH and the phosphate will be low will be RTA. RTA basically happens due to defect in the receptors of the tubular receptors of kidney. Due to basically this also an absorption defect, but it happens specifically in the tubules. I'm not going into the detail. So RTA, if a refractory rickets child presents with blood gas being acidotic, then the child is more likely to have an RTA. Okay. And at the same time, if phosphorus is low or normal, but the blood pH is normal, the blood gas is normal, next step is to measure the PTH and calcium. So നേരത്തെ പറഞ്ഞ പോലെ if it's a vitamin D deficiency or vitamin D dependent means it is not deficiency per se, it is due to the problem with the receptors. So vitamin D നമ്മുടെ ബോഡിക്ക് ചിലപ്പോൾ ഉണ്ടാവും, പക്ഷേ vitamin D ആക്ട് ചെയ്യേണ്ട റിസപ്റ്റേഴ്സിന്റെ പ്രശ്നം കാരണം വരുന്നതാണ് vitamin D dependent rickets. It is also called as vitamin D resistant rickets. But again, the same thing will happen. അല്ലെ, vitamin D ബോഡിക്കകത്ത് ആക്ട് ചെയ്യാൻ പറ്റുന്നില്ല, കുറവുള്ളതുകൊണ്ടല്ല, പക്ഷേ vitamin D ബോഡിയിൽ ആക്ട് ചെയ്യാൻ പറ്റാത്തൊരവസ്ഥയിൽ എന്തുണ്ടാവും? Calcium will obviously be decreased. PTH will increase as a compensate response to increase the vitamin D. But vitamin D is still not increasing. So there will be high PTH and low calcium. But if there is normal PTH, normal calcium, and only phosphorus is affected, it is going to be an entity called hypophosphatemic rickets. So I hope this algorithm is clear. Okay, this algorithm has to be clear for all of you. Now we come back to this question. Serum calcium is normal and AL and PTH is normal, which means calcium normal and PTH normal, and which means it is not going to be vitamin D deficiency, nor is it a vitamin D dependent rickets, because calcium has to be low, PTH has to be high in such a case, so it is not there. Bicarbonate is 22. So bicarbonate is a marker of acidity. It is a marker of metabolic acidosis. Normal bicarb is 20 to 24 in a blood gas. If it is low, it means that the baby is acidotic, but bicarbonate is normal, which rules out a renal tubular acidosis. So that is normal. So, and ALP is elevated and phosphate is low. Now, the only thing which you are left is this hypophosphatemia rickets. So that is going to be the answer. So the answer for this question is going to be B, hypophosphatemia rickets. So this approach is a key approach. You have to remember this when you approach a question with rickets. This question was asked last year in NEET UG. So this question, not the exact question, but this question with a similar framework was asked last year in NEET PG. So you should remember that these things have to be kept in mind. This algorithm is very important to solve a question of refractory rickets. Okay. Next question: a 3-year-old presented OPD with complaints of poor weight gain, poor appetite, and frequent abdominal pain. Clinical and lab workup, gluten-free diet was given, and general improvement in clinical condition was noted. What was the probable diagnosis? A simple, straightforward question. Frequently poor appetite and abdominal pain with poor weight gain and gluten-free diet. So gluten-free diet and individual condition, there is only one possible diagnosis that is going to be celiac disease. The answer is going to be celiac disease, and it is associated with it is HLA DQ2 and DQ8 have increased predilection for celiac disease. Okay, and yeah, that is our this question. Come to the next question. Which among the following is not an absolute criteria in the definition of severe acute malnutrition? Weight for height less than -3 standard deviations. Mid-upper arm circumference less than 11.5 centimeters in the age group of 6 to 59 months. Bilateral pitting pedal edema and body mass index less than 13. So, body mass index is not a criteria for defining severe acute malnutrition. Okay. If you want to describe severe acute malnutrition, there are only 3 criteria. Either the weight for height or the weight for length should be less than -3 standard deviations, a mid-upper arm circumference less than 11.5 centimeters, or the presence of bilateral edema. ഈ 3 കാര്യങ്ങൾ ഉണ്ടെങ്കിൽ you can define as severe acute malnutrition in a child. The body mass index doesn't fit in, and that is going to be the answer. So, when you talk about severe acute malnutrition, you should remember something, a mnemonic which is called shielded. Shielded is a simple mnemonic to remember the acute steps in management of a child who presents to your OPD or to you with severe acute malnutrition. So, S in shielded stands for sugar. So, they are prone for hypoglycemia. H stands for hypothermia. They are prone for low temperatures, which can affect their thermodynamic stability. I stands for infections, for which we have to treat them adequately with antibiotics. EL stands for electrolytes, for which you have to replenish them with electrolyte supplements. D stands for dehydration. Obviously, they are acutely malnourished, so they have a huge risk of dehydration. അതിനാണ് നമ്മൾ ORS ഒക്കെ പലർക്കും കൊടുക്കുന്നത്. And the last D stands for deficiency of micronutrients. So these are the 6 important things which you have to encounter in the acute phase of severe acute malnutrition. And treatment of this acute phase is what we call as stabilization. So this happens up to usually 7 days. It's not 1 to up to 7 days. When a child presents to you and you start treatment of acute malnutrition, the first 7 days of treatment is crucial, where you encounter these 6 elements of shielded: sugar, hypothermia, infection, electrolytes, dehydration, and deficiency of micronutrients, and that is called the stabilization phase, which lasts till 7 days. After 7 days, till 6th week of life, it is called the 6th week of the illness. It is called the rehabilitation phase, where you start feeds as F100, F100, F75, hyperosmolar feeds are started to replenish the protein stores in the body. So the acute management of shielded happens in the stabilization phase, and rehabilitation phase, you have other things such as cassette growth, sensory stimulation, follow-up recurrence, and all coming in the dehydration in the rehabilitation phase. And another key concept is what are the definitions of primary and secondary failure. You start management for severe acute malnutrition, and when do you call it a primary failure, or when do you call it a secondary failure? So, primary failure to respond is when the baby or the child fails to regain appetite despite starting adequate management by day 4 of life, or fails to start losing edema by day 4 of life. അല്ലെങ്കിൽ day 10 edema അതേപോലെ നിൽപ്പുണ്ട്. So failure to sluice edema on day 4 of life or presence of edema on day 10 of life is primary failure. Or failure to gain at least 5 grams per kg per day of weight by day 10 of life is called as primary. So E4 conditions is what we call as anything. Even if one of this is meant, you call it as a primary failure to respond to the acute management which you have initiated for severe acute malnutrition. Similarly, secondary failure happens during the rehabilitation phase. The primary failure happens during the stabilization phase where your management for the stabilization phase is inadequate. സോ അപ്പറ്റൈറ്റ് ഗെയിൻ ആവുന്നില്ല, നാലാമത്തെ ദിവസമായി അപ്പറ്റൈറ്റ് ഗെയിൻ ആവുന്നില്ല. ഇഡീമ നാലാമത്തെ ദിവസമായിട്ടും ഇഡീമ കുറയുന്നില്ല. ഇഡീമ 10ാം ദിവസമായിട്ട് നീർക്കെട്ട് അവിടെ തന്നെ ഉണ്ട്. അല്ലെങ്കിൽ അറ്റ്ലീസ്റ്റ് 5 grams per kg per day by day 10 the baby has not failed to gain. But if it happens in this rehabilitation phase, it is at least 5 grams per kg per day for 3 consecutive days. So that is called a secondary failure to respond. So in this question, they have asked what is primary failure to respond. എല്ലാം primary failure ആണ് except which. So failure to start shedding edema by day 4, correct അല്ല, നമ്മൾ പറഞ്ഞതേ ഉള്ളൂ. Taken appetite by day 4, it is also correct. At least 10 grams per kg per day gain by day 10, this is a wrong statement. The baby should at least gain 5 grams per kg per day on day 10. If the baby doesn't, that is called as a secondary failure to respond. And child has presence of edema on day 10, that is also a criteria for calling it a primary failure to respond. Okay, so the answer is obviously going to be option C. Now, a 2-year-old child is brought to the emergency at 3 a.m. with fever, barking, cough, and stridor, only well crying. Child was able to drink normally. On examination, respiratory rate is 36 per minute and temperature is 39.6. What will be your next step? Again, they have given so many clues in this question itself. 2-year-old child, fever, barking, cough, and stridor. So in this question, whenever they have mentioned stridor in a question, it means that the child is having some sort of an upper airway obstruction, because stridor is a sound which is produced due to the passage of turbulent air through a closed glottis. That is, forced expiration of air through a closed glottis causes a stridor. And this usually happens when there is an obstruction in the upper airway at the glottic level, subglottic level, or the supraglottic level. So upper airway obstruction will mark when a stridor will happen. So this, you are dealing with a child who has an upper airway obstruction, or probably upper airway obstruction is due to an infection, because child has fever and a barking cough and was able to drink normally. So a barking cough and stridor in an otherwise normal child points to the diagnosis of something which we call as croup or acute laryngotracheobronchitis. It is a viral infection which is usually caused by parainfluenza viruses, predominantly parainfluenza virus type 1 and 3. All the other viruses such as RSV, metapneumovirus can also cause this, where the child will have sudden onset of a sudden barky cough, upper respiratory infection ഉണ്ടാവാം തുടക്കത്തിൽ, and then they'll have upper airway obstruction because of the infection. There will be edema, there is significant inflammation edema of the upper airway, which will lead to a stridor because of airflow closed flow passing through a closed focus. And in X-ray, if you notice, you'll see something called as a church top sign. Church പള്ളിയുടെ മണ്ടയിൽ കുരിശിരിക്കുന്ന കണ്ടിട്ടില്ലേ, അതേപോലെ church top sign or the pencil tip sign or something called a steeple sign, which is a marker of the upper airway obstruction. The lumen is narrowed so much that when air passes through this lumen, it produces a characteristic stridor. So this is called a croup. So how do you assess croup? The croup will be either mild or severe. Mild ആണെങ്കിൽ the child will be having stridor and cough, but they will be comfortable at rest. But in severe, they have frequent cough with marked stridor and visible respiratory retractions. That is why they have given this respiratory rate is 36 per minute. So this is normal for it. The child is not tachypneic. Child is not having increased work of breathing, which means the child is comfortable at rest and that is going to be mild. In mild and severe stridor, the next step of management is to give steroid, because they have a lot of inflammation in the upper airway, which is causing all these issues. So what are steroids? They are anti-inflammatory agents. So when steroids are given, they'll reduce inflammation and can relieve the stridor or the obstruction. That is why the first step is to give 0.6 mg per kg dexamethasone as the modality of choice. And along with it, you can also give nebulized adrenaline, again a steroid nebulization in severe to moderate group, and you can observe them. പക്ഷെ മൈൽഡ് സൈഡർ ആണെങ്കിൽ ഈ അഡ്രിനൽ നെബുലൈസേഷൻ്റെ ഒന്നും ആവശ്യമില്ല. ഗീവ് എ സിംഗിൾ ഡോസ് ഓഫ് ഡെക്സ and you can counsel the parents about the severity of the illness, danger signs, and you can discharge them. Okay, that is the protocol. So in this case, the child has a mild stridor, and what's going to be the next step? Answer is going to be answer B, dexamethasone administration. Okay, it is going to be dexamethasone administration. Now, go to next question. So you have a 6-month-old baby with difficulty in breathing of 2 days duration. Okay. Again, and in an examination, you find that the baby is not having significant fever, and bilateral wheeze is there. They have bilateral wheeze, and chest X-ray shows a bilateral hyperinflation of the lungs with normal WBC count. So you have a 6-month-old child with no significant fever, and they have a examination. You have bilateral wheeze, but the WBC count is normal. Okay. So what is the probable diagnosis? They have given the X-ray as well. So whenever you see more than 8 spaces, or X-ray, if they are giving a pediatric X-ray or a chest X-ray, and if they are giving more than 8 spaces, that is hyperinflation. We can see that 1, 2, 3, more than 9 spaces, hyperinflation of the chest. And this looks typically like a viral prodrome. Value fever, it's difficulty. This looks like a viral infection. And there is also a wheeze, which means that the alveolar component of the lungs has been involved. So, and this happens in an infant. So, an infant with a viral history presenting to you with a hyperinflation of chest and wheeze with a normal WBC count is going to be something called acute bronchiolitis. Okay, this is an infant. If this was an older child, you can also think of something called bronchial asthma, but bronchial asthma has very rarely, it is an onset in very infant age group. This is acute bronchiolitis. What happens in foreign body aspiration? Foreign body aspiration usually will cause upper airway obstruction, and the predominant manifestation will be a stridor and not a wheeze. So, or otherwise, if it goes to the bronchus, foreign body bronchus, it can cause wheeze, but it will be unilateral wheeze. It won't cause a bilateral wheeze. So foreign body obstruction will either cause a stridor or it can cause a unilateral wheeze, but rarely, but it will never present with bilateral wheeze, because bilateral wheeze two foreign bodies will have to go to both the bronchus, which is very, very, very unlikely. And this is not a pneumonia because the child doesn't have fever, child doesn't have a raised WBC count, and X-ray doesn't show hyperinflation. There is no patch in the X-ray. So this is more in favor of an acute bronchiolitis, which is an acute inflammation of the bronchioles, and the most common agent is the RSV, respiratory syncytial virus. Also know that this is a clinical diagnosis. For bronchiolitis to be diagnosed, you don't need an X-ray, you don't need blood investigations. These are all supplemental evidences. The only thing you need is a clinical diagnosis. You auscultate the baby, you look at the age group of the baby, you diagnose it to be bronchiolitis. And treatment is solely based on symptomatic relief and maintain hydration and oxygenation. And you can also give nebulization with saline, salbutamol, but it's questionable. And in bronchiolitis, there is no role for antibiotics and systemic steroids. There is no role because it's a viral infection. Antibiotics and inflammation also steroids, there is no role for steroids, it seems, in bronchiolitis. So it is usually self-limiting. Okay, and it's a clinical diagnosis. Okay. Now, a child with pyoderma becomes toxic in presence of respiratory distress, and this radiography shows patchy areas of consolidation, multiple thin-walled air cysts. So this is again a straightforward question. A child presents to you with pneumonia, and you find that there is a cyst in the lungs, and this looks like thin-walled. You can find that there's hypolucency inside. Thin-walled air-filled cyst with a background of child with a pneumonia is going to be something called, this is called something is called as a nematocele, and the diagnosis is going to be Staphylococcus aureus. Next question, a 3-year-old male newborn presents to with noisy breathing, which typically worsens after crying or when kept in supine position, however hemodynamically stable with minimal distress and maintaining saturation in room air. What is your most likely diagnosis? Again, most common causes stridor and noisy breathing in an otherwise a normal infant is going to be something called laryngomalacia, which is due to the flabbiness of the epiglottis. The epiglottis is something like an omega-shaped epiglottis. When loose epiglottis, the larynx is also very loose. So what happens is whenever the baby is trying to feed or is trying to cry, due to the stretching of larynx, there will be abnormal narrowing of the lumen, and this will result in the stridor sound which we usually hear. So this noisy breathing which we hear in laryngomalacia is nothing but stridor. And as I told, stridor is due to an upper airway obstruction. So upper airway obstruction in a normal newborn, otherwise with no distress, is going to be laryngomalacia. And in the case of laryngomalacia, you usually wait and watch till the age of 2 years of age. If it is still persisting more than 2 years of age, you might go for surgical interventions or interventions such as laser therapy. Also, sometimes rarely laryngomalacia, if it is severe, the child can progress to respiratory distress before 2 years of age. So if a child with laryngomalacia progresses to severe distress, that is also an indication for an intervention or a possible surgical intervention in the child. അല്ലെങ്കിൽ നമ്മൾ usually wait and watch ആണ്. We usually employ the possible policy of wait and watch in 2 years of age. Now, which of the following is not a major entity for the diagnosis of acute rheumatic fever in a high-risk population as per the modified Jones criteria? Very straightforward question. Polyarthritis, subcutaneous nodules, prolonged peer interval, and monoarthritis. You know that polyarthritis, subcutaneous nodules, monoarthritis, okay, they are a part of the major criteria. The answer is going to be prolonged PR interval. These are all lab criteria. So this is Jones criteria. Otherwise, Jones criteria is very important in medicine as well as pediatrics. They can be asked. So you should know what are the major manifestations. The major manifestations in the carditis, polyarthritis, erythema, nodules in choreo, and minor manifestations is arthralgia, fever, ESR, CRP, and prolonged PR interval ECG are all minor manifestations. And we should also be able to elicit an evidence of a recent group A streptococcal infection because you attribute rheumatic fever to the group A streptococcal infection in the past. So you should either have a positive throat culture or a rapid antigen test or an increasing antibody titer. And you should also know what is a low risk population and a high risk population. The definition for this major manifestation will change for low risk and a high risk population. For a high risk population, even monoarthritis is a major manifestation. Even monoarthritis is a major manifestation in a high risk population. But in a low risk population, only polyarthritis or polyarthralgia is a major manifestation. So in a low risk population, okay. So low risk population only if the child has polyarthritis, that is a major manifestation. While even a monoarthritis is a major manifestation in a high risk population. So you should know what is low risk population and high risk population. You should know what are the criteria. So usually 2 major plus 1 minor, or 2 major manifestations alone, or 1 major with 2 minor, or is sufficient to confirm the diagnosis of rheumatic heart disease or rheumatic fever. But if it's a recurrent attack, even if there are 3 minor manifestations, that is sufficient to diagnose that it is a recurrent attack. Okay. So either 2 major manifestations alone or 1 major with 2 minor, or if it's a recurrent attack along with the above mentioned 2, if there are 3 minor manifestations, that is enough to diagnose acute rheumatic fever. Another straightforward question which has been asked 2 years back: what is the osmolarity of WHO low osmolar ORS? The answer is 245 milliosmolars per liter. So you should know the components of WHO recommended ORS. The answer is 245. You should know how many grams, how many millimoles per liter of sodium adds up to 240. Sodium, chlorine, glucose adds up to 245. So sodium is 75, glucose is 75, chloride is 65, and potassium sodium citrate is 10, which adds up to 245 milliosmoles per liter. And if you look at the grams for the composition in isolation, sodium chloride will be 2.6, glucose will be 13.5, potassium chloride will be 1.5, and 2.9 grams of trisodium citrate. So this will be the normal composition when it comes to grams. So this totally adds up to 245 milliosmoles per liter. That is the osmolarity of WHO low osmolar ORS. Now going to neonatology. So which of the following statements regarding erythema toxicum is false? Okay. It is a benign skin condition, more commonly seen in preterm neonates. Lesions usually start over the trunk, which usually contain eosinophils, and the condition is self-resolving with no specific treatment. So very often you will find this condition when you're sitting in the OPD. Sometimes the mothers or the parents will be anxious to bring the child, and the child will look like this. They will have significant small erythematous rashes spread all over the body, usually starting from day 3 to day 5 of life. So this is not at all pathological. This is perfectly normal and is called erythema toxicum. Erythema toxicum usually happens because of eosinophilic migration. The lesions are usually because of migration of eosinophils, and this will usually start over the trunk, happens from day 1, day 3 to day 7 of life, and usually is a very self-limiting condition with no specific treatment. You can just reassure the parents and send them home because they are not going to spread. But the catch is that it is exclusively or very commonly seen in term units and not in preterm. So if they give the options, the answer is going to be A, because erythema toxicum is more commonly seen in term units and not preterm units, and usually starts over the trunk. Okay. Next question. Physiological jaundice in neonates is characterized by all except appears predominantly between 1 to 3 days of life, more often does not require treatment, can involve the palms and soles, reduced RBC lifespan units in a risk factor. So normally 80% of the jaundice which we encounter is going to be physiological jaundice. Physiological jaundice happens in almost 80% of neonates who are born. And it happens mainly because of the reduced RBC lifespan, the decreased enterohepatic circulation, hepatic immaturity. A lot of factors are non-physiological jaundice comes into play. But the catch is that physiological jaundice again will usually occur within 1 to 3 days of life and will not usually require treatment. Phototherapy ആവശ്യം വരാറില്ല. അതേപോലെ തന്നെ usually resolved by themselves, just a self-limiting jaundice. But it can never involve the palms and soles. So if you find any baby with involvement of palms and soles, that is definitely going to be a pathological jaundice. So the criteria for physiological jaundice in usually happens more than 24 hours of life. Pathological jaundice can set in less than 24 hours of life. So usually significant jaundice for a baby in the first day of life is more likely to be a pathological jaundice than a physiological jaundice. And it can usually last for more than 2 weeks in term and more than 3 weeks in the preterm. And the rise is usually going to be significant. You can have a rise more than 5 milligrams per deciliter per day with something called acute bilirubin encephalopathy if not treated. So if pathological jaundice rises and if it is not adequately treated, it can cross the bilirubin can cross the blood-brain barrier and cause something called as chronic thirst, and this can lead to acute bilirubin encephalopathy with involvement of palms and soles is also possible in pathological jaundice. So pathological jaundice will physiological jaundice will never involve the palms and soles. Okay. So some cause of pathological jaundice include the pathological jaundice in the causes on hemolysis, hemolytic jaundice such as RH, severe RH incompatibility, AV incompatibility, and diseases such as pherocytosis. All these are causes of pathological jaundice in the newborn. And next question: a 4-day newborn is referred to a tertiary center with complaints of fever, severe jaundice, and poor sucking. Baby in order to be stuporous with intermittent arching of the trunk and hypertonia. Which of the findings is not a chronic finding in this condition? So again, this means that the bilirubin is very high, 23 milligrams per deciliter, and the bilirubin could have crossed the blood-brain barrier since it is very high, and the baby has manifestations of something called as bind. Bind means bilirubin-induced neurological dysfunction, bind or acute bilirubin encephalopathy, which we earlier used to describe as chronic thirst. Now the terminology for chronic thirst has changed. It is called as bind. Bind means bilirubin-induced neurological dysfunction, and this baby has all the features of bind. So what are the classical tetrad? The chronic thirst has a classical tetrad, which includes sensorineural hearing loss, vertical gaze palsy, enamel hypoplasia, and chorioathetoid CP. ഇതിൽ നാം ശ്രദ്ധിക്കേണ്ട കാര്യം CP occurs basically because of deposition of the bilirubin in the basal ganglia. The predominant site for deposition of bilirubin, excess bilirubin, is going to be the basal ganglia of the brain, which can lead to abnormal movements in cerebral palsy. That is why it is called chorioathetoid cerebral palsy. The deposition of bilirubin in the cochlear tufts can also cause sensorineural hearing loss, and the eye gaze centers can be affected, causing vertical gaze palsy, and enamel hypoplasia can also happen due to deposition in the teeth. So this is described as a classical tetrad of chronic thirst. So the answer is going to be B. They will present with vertical gaze palsy, not horizontal gaze palsy. Next question. Bag and mask ventilation during resuscitation is absolutely contraindicated. Very straightforward question. In congenital diaphragmatic hernia, you don't use bag and mask ventilation. So what happens in CDH? CDH is basically a defect. Diaphragmatic defect where the contents of the intestine will eviscerate from the intestine into the lungs. So basically what will happen if you give bag and mask ventilation, it is only going to cause more and more, if you give more and more positive pressure will lead to more and more air entering the abdomen. It is not going to effectively ventilate the lungs, and the mechanical compression is only going to worsen. The abdomen is only going to get inflated, and the lungs are only going to get compressed more. So that is why bag and mask ventilation is an absolute contraindication in congenital diaphragmatic hernia. A similar question: a newborn baby presented with respiratory distress on examination. Heart sounds were auscultated in the right hemithorax. So the heart, which means either the heart is not in position or the heart has been pushed to the right. Or left side the heart is in the right hemithorax, and auscultation of the left side revealed gurgling sounds. Chest X-ray was taken. So this was the chest X-ray. What is the most common catastrophic defect? Again, a straightforward question. This is a congenital diaphragmatic hernia, where the intestinal contents which you are seeing here has invaginated through the diaphragmatic weakening and has come to the left side of the lung, pushing the heart to the right. So that is why the heart sound is heard towards the right, And the gurgling sound is because of the peristaltic movements of the intestine. So, which is the most common site of CDH? The answer is going to be D, left posterolateral Borch-Delex hernia. There are two more types of CDH. There is a left posterolateral type, which is called as the Borch-Delex hernia. Second type is called as the anteromedial type, and it is also called as the Morgagni's hernia. So, the most common site is through the posterolateral aspect, and this is called as the Borch-Delex hernia. This was a question which was asked in last meet. Doing what an athletic topic. And then there is something which similar. This is an infant with similar history with cyst-like structures in the right lung or around right lung, sometimes left lung, it's also possible. And rectal infections can lead to something which is called CPAM. CPAM basically means congenital pulmonary airway malformation. So basically, lung developmental issue karanam, the infant will have features of respiratory distress. They will have cyst-like lesions in the lung when X-ray is taken, and frequently they'll require oxygen support. So this can be an airway malformation. This is called congenital pulmonary airway malformation. Next question, late onset sepsis manifests after. So neonatal sepsis, when we define, there are two definitions. There is either an early onset sepsis which happens due to the maternal factors. Usually this happens when the mother is infected or a mother has an genital infection and the baby comes out by labor, usually the baby gets infected. So this happens between birth to less than 72 hours. So more those can go on early onset. Late onset sepsis usually happens because of complications related to the healthcare providers. Because of our handling, because of the healthcare workers or the providers not maintaining adequate hand hygiene or strict precautions, they can have sepsis. That is called late onset sepsis. And for prematurity, the most common type is early onset sepsis. And usually late onset sepsis will manifest after 72 hours of life. So how do you define neonatal hypothermia? Again, neonatal hypothermia is usually defined as a temperature less than 36.5. So the basic definition of hypothermia, normal newborn temperature എന്താണെന്നാണ് question എങ്കിൽ that is going to be 36.5 to 37.5 degrees Celsius. So severe hypothermia is defined as a temperature which is less than 32. So what are the classification of hypothermia? You can either have a mild hypothermia, which is called cold stress, where temperature is between 36 to 36.5. So it is a very narrow range. And moderate hypothermia is when temperature is between 32 to 36 degrees Celsius, and this is a danger sign for the baby. But if the baby has severe hypothermia, it means that the temperature is less than 32 degrees Celsius. So if a baby has a temperature less than 32 degrees Celsius, that is called severe hypothermia. But if we ask you what is the definition of hypothermia as such, that is going to be a core temperature less than 36.5 degrees Celsius. And how do you measure the core temperature for a newborn infant? The rectum is the most preferred site for measurement of the core temperature. Rectum is usually the most common site, but it is difficult to in rectum. So usually you take under the axilla. So abnormal Morose reflex is when persistence of the reflex occurs for more than. Again, this is an easy question. Morose reflex usually disappears by 3 months of age. Persistence of Morose for more than 6 months is indication that it is going to be abnormal. So you should know when the primitive reflexes, especially Morose reflex, palmar grasp, plantar grasp, all appear and when they disappear. So Morose reflex usually disappears by 3 to 4 months of age. Plantar grasp disappears 6 to 8 months of age, and tonic neck reflex disappears by 6 months of age. The table is given in OPKI as well. You should all table is also very important. You should go through this table. And what are the causes of premature disappearance of Moro? Sometimes we won't be elicit Moros in a baby after born. So that can be a sign of a significant brain injury where the baby is not able to process the cranial nerves are not able to process the pathways of the Morose reflex. This can happen due to an infection, a hemorrhage, or a birth injury or an asphyxia. And asymmetrical Moro, where you have normal Moro in one side and in another side the Moro is absent, can usually happen due to a fracture. ഒരു സൈഡിലെ clavicle fracture ആണെങ്കിലോ അല്ലെങ്കിൽ ആ സൈഡിലെ brachial plexus injury ഉണ്ടെങ്കിൽ baby won't be able to move that limb. So that can be a cause of asymmetrical Moro. And prolonged Moros, which is persisting, can be a sign of cerebral palsy. So this is also a question of the examiners. What are the cause of asymmetrical Moro? Suppose you do Moros in a baby and you find that the baby has a right-sided normal Moro and left-sided there's absent Moro. It can either be due to the damage to a nerve, a cord, or a fracture of the clavicle, which innervates the area. Now, single gene controlling more than one phenotypic effect is called a trivial question. It is called Pleiotropism. So pleiotropism is when a single gene will be able to control multiple unrelated traits. Another trivial question. A 19-year-old female with short stature, widespread nipples, webbed neck and increased carrying angle, and short fourth metacarpal primary amenorrhea. ഞാൻ പറയേണ്ട കാര്യം പോലും ഇല്ല. Whenever you see a female phenotype with a webbed neck, increased carrying angle, and a primary amenorrhea with short fourth metacarpal, it is going to be indicative of what? It is going to be Turner syndrome, and the phenotype is going to be 45XO. Which of the following is wrong regarding the interpretation of quadruple test for the diagnosis of Down syndrome? Again, quadruple test is a very important test. It is used to measure first. It is used to measure the risk of Down syndrome in the first trimester. So there are four components to it. There is something which is called usually we write as high U. Okay, high which means HCG, A which means alpha fetoprotein, I which means inhibin A, and U which means estriol. Unconjugated estriol. So high U, HAIU. That's we use in mnemonic for quadruple test. So in quadruple test, H and I will be elevated and A and U will be decreased. So H will be elevated, A will be decreased, I will be elevated, and U will be decreased. Which means HCG will be increased, alpha fetoprotein will be decreased, inhibin A will be high, and estriol will be decreased. So the quadruple test will have increased inhibin A levels and not inhibin B levels. Inhibin B levels is a hormone that is associated with the reproductive system and is not a marker for quadruple test in the Down syndrome. Okay, and diagnostic test, if they ask you what is the diagnostic test for diagnosis between diagnosis of Down syndrome, is going to be a karyotype measurement, which can either be due to a either done to a chorionic villus sampling or an amniocentesis. So chorionic villus sampling is done between the age of 8 to 10 weeks, and amniocentesis is done after the age of 16 to 20 weeks. So these are the diagnostic uh, tests for clinical diagnosis of Down syndrome. Next question. So what is the risk of producing a child with Down syndrome? A father as a carer balance 21 to transmission. കുറച്ച് fast ആയിട്ട് പോവാണ് because we are very short of time. So a 21-21 translocation is basically called as a balanced translocation. It happens when the father essentially or mother, even the mother is a 21-21 translocation carrier. So either of the parent has this translocation, there is a 100% risk of the child having Down syndrome. So if it is a 21-21 translocation, you can note there is a 100% recurrence that the next child or the offspring will have a Down syndrome. Normally, if it is from the mother, with a balanced translocation, the risk is going to be 10% and 5% when it is a father. But if it's a balanced translocation, it is going to be 100% recurrence. So child presents to the OPD with recurrent sinusitis and recurrent chest infections. Chest X-ray is shown here. The X-ray open what all things can you can notice that the heart is towards the right. Okay, the heart is towards the right, so possibly it can be a dextrocardia. At the same time, we notice that this thing, what is this thing? This thing is called the gastric bubble. The gastric bubble should normally in the right side. Now this is also twisted to the left. So if there is a dextrocardia and the gastric bubble is also twisted to the left, it means that it is called a situs inversus. So situs inversus dextrocardia and situs inversus you could also look at the gastric bubble of the in the X-ray, and the stomach should also be twisted to the left, which means that the entire intestine will be in the left side. Full dimension will be changing. So this is a dextrocardia. So it's a situs inversus. So recurrent chest infections, a situs infection, situs inversus, and sinusitis is a feature of cartagenous syndrome. The triad of cartagenous syndrome is chronic lung infections, so bronchiectasis, chronic rhinosinusitis, and situs inversus with dextrocardia. A male infant with distension of abdomen shortly after birth with passage of minimal meconium, subsequently full thickness biopsy. Now, this is again a classical description of Hirschsprung's disease, where abdominal distension in a male infant with minimal meconium passage probably due to aganglionic rectum or aganglionic large intestine. So the rectal biopsy will show what? They'll typically show lack of ganglion cells, and the findings suggest of Hirschsprung's disease. So next question, a neonate suspected of suffering from necrotizing enterocolitis and further examination, Bell stage 1 NEC has been diagnosed. How do you manage? So basically, this is something which you have to remember again. NEC staging called the modified Bell staging, and you have to remember especially the radiological findings which stage you find which. For example, pneumatosis intestinalis, where the intestine is leaked with abdominal air, is found in stage 2A. So stage 2A and pneumatosis intestinalis starts, and pneumoperitoneum of stage 3B is the advanced to the last stage of NEC, where the abdomen has perforated and it is filled with air. So you have to notice when coming to the management that stage 1 to stage 3 is conservatively managed. Till stage 3A, the management is going to be antibiotics and just nil per oral. Surgical intervention is required only for which stage of NEC? Unless the NEC has made the abdomen perforate, there is no need for surgical intervention. For surgical intervention, നമ്മൾ ചെയ്യുന്നത് ഒരേ ഒരു stage of Bell's criteria. Stage 3B is the only stage which warrants surgical intervention. Stage 1 to stage 3A requires only medical intervention. So if they give you a description of stage 3B and ask you what is next intervention, then you have to go for surgical method or surgical interventions. So stage 3B is usually when you have signs of pneumoperitoneum. So they can give you an X-ray where there is a lot of air in the peritoneum, such as the rising football sign. Air under the diaphragm. So that's a typical sign of stage 3B NEC where you will go for surgical intervention. Otherwise, NEC can be managed conservatively. Specifically, I'm saying again, you have to remember the radiological signs with each and every type of NEC. So 6-week old neonate with I will finish in another 10 minutes. We'll finish it off by 9:15. I think I'll be able to wind it up. So 6-week old neonate with repeat episodes of non-bilious vomiting. Okay, so not the catch point here. Non-bilious vomiting in a 6-week old neonate, and the ultrasound is given below. So what is the diagnosis? So you have the ultrasound picture here. So this is basically essentially a picture of the stomach duodenal interface. And E കാണുന്ന this thing is the hypertrophied pylorus. This is stomach, and you can notice that this is the hypertrophied pylorus. So what is this? The stomach to the pylorus. The pylorus is the entry canal from the stomach to the duodenum, and this is getting hypertrophied. So this is called infantile hypertrophic pyloric stenosis, which will usually manifest at the 4 to 6 weeks of life, with the child having repeated episodes of non-bilious vomiting. And sometimes during feeding and crying, they can also have an epigastric mass, an olive-shaped epigastric mass. Classical olive-shaped epigastric mass. This happens due to the pylorus becoming prominent. The already hypertrophied pylorus becomes prominent when the baby is feeding, which will lead it to appear like an olive-shaped mass. So this is a classical description of an infant with infantile hypertrophic pyloric stenosis. And the ultrasonographic criteria is based on the thickness and the length. If the thickness of the pylorus is more than 4 millimeters or the length is more than 16 millimeters, in ultrasound of the abdomen, then it confirms the diagnosis of IHPS. So, but the catch is it is a non-bilious vomiting. Okay, it presents a non-bilious vomiting. So this is IHPS. So, which is the most probable metabolic abnormality you expect in the scenario? In the നേരത്തെ പറഞ്ഞ പോലെ palpable epigastric mass in an infant with recurrent episodes of non-bilious vomiting. This is a question that has been asked over and over again and again. At least 10 times this question has been repeated. So this is again a very important question. IHPS most common metabolic abnormality is what? So basically, I've mentioned below, IHPS is with what non-bilious vomiting, which means that the baby is losing significant amount of hydrogen ions and sodium ions via your vomitus. So this will lead to a state of alkalosis, and that is why the baby is prone for hypokalemic, hypochloremic alkalosis because of the multiple episodes of vomiting. Baby is losing potassium, H plus, and chlorine ions via the vomitus. So that is why the typical manifestation is going to be a hypokalemic, hypochloremic alkalosis. Potassium is low, chlorine is low, H plus is low, and this is the hallmark metabolic abnormality. Now, what happens in the late stages of severe stages of HPS is that ഇതിങ്ങനെ ഒരുപാട് sodium potassium lose ചെയ്യുമ്പോൾ what happens is the body will have a compensatory mechanism. When the body will try to retain sodium by itself, when there is a loss of sodium, potassium, H plus, etc. by vomitus, the body's primary mechanism is to retain sodium and water. This happens in later stages where the body will try to retain sodium at the expense of H plus. So although there is alkalosis, the body's compensatory mechanism will be to replenish the lost sodium through vomitus. So sodium and water will be the first ions that the body will try to replenish. So sodium will be retained at the expense of what? Body will excrete H plus out. So there will be something that is called paradoxical aciduria, which can also happen. So a condition where there is metabolic alkalosis with paradoxical aciduria in the later stages is IHPS, which predominantly happens because of sodium being lost through the vomitus. Body tries to retain sodium by reabsorbing sodium at the expense of the H plus ions. The H plus ions are excreted out, and this causes a paradoxical aciduria. Okay. So preterm newborn baby with history of projectile bilious vomiting shortly after birth and annual scans showed polyhydramnios. The X-ray shows this. This is classically a double bubble sign. And our stomach and duodenum, there are two distinct bubbles. And after duodenum, nothing is visible. Stomach baki in the center visible, which means there is some obstruction here which does not let in air outside. So this means there is an ectasia of duodenum. So this is a classical double bubble sign. It's also found in duodenal atresia, annular pancreas, and also volvulus, where there is a twisting of intestines so that there is an obstruction at some point of level. So, നമ്മൾ ശ്രദ്ധിക്കേണ്ട കാര്യം there is a bilious vomiting, right? Why does duodenal atresia, anal pancreas, and present bilious vomiting? The answer lies in the anatomy. So, if you notice the first part of duodenum, you notice that the bile duct opens to duodenum at the ampulla of the tear. Correct? So, if the obstruction happens distal to the ampulla of the tear, bile will be retained, which will be vomited out. That is why there is bilious vomiting in duodenal atresia, which usually happens distal to this opening into the ampulla of the tear. So, any obstruction of atresia of the duodenum, which happens distal to the ampulla of wet air, can present with bilious vomiting because bile duct opens into the duodenum at the level of this ampulla of wet air. So that is why even annular pancreas. What is annular pancreas? There is an extra pancreatic tissue which encircles the duodenum, compressing the duodenum, and because of this, there is no passage. There is an obstruction from this duodenum to the next passage of intestine. So this can also lead to obstruction distal to the ampulla of Wetter, which will present as bile being vomiting out through the upper tract. So this is also common cause of bilious vomiting. Now there is something which is also called as a triple bubble sign, which is associated with jejunal atresia. You see stomach, duodenum, and jejunum, nothing beyond that. So triple bubble sign is a feature of jejunal atresia. The most common type from this image, this is a classification called the gross classification of tracheoesophageal fistula. The tracheoesophageal fistula there is a kind of there is either an atresia of the esophageal end or a tracheal end, or esophageal end or the tracheal end, or there can be fistula connecting this. So the most common type is called the type C type. So if you notice, there are 5 types: A, B, C, D, and E. Okay. So in the A means there is a pure esophageal atresia. Esophagus ends, there's a blind pouch. And there is the trachea, there's a pure tracheal atresia, there is also pure esophageal atresia. So trachea ends, there's a blind pouch. Esophagus also ends, there's a blind pouch. There is no connection between the trachea and the esophagus. This is called pure atresia, that is type A. In type B, esophageal atresia is there. Pure atresia is there, but there is a fistula between the trachea and the trachea and the proximal esophagus. So this is called atresia with proximal fistula. There is a proximal fistula. So here there is a pure atresia. And esophagus connected. Trachea is here, esophagus is here, no connection. There is a pure atresia. Here there is a connection between the proximal esophagus and the trachea, but there is no connection between these two, distal and the proximal esophagus. So this is called the proximal fistula with distal atresia. Type C is the most common type where you have a distal fistula with a proximal atresia. This is the most common type. So this is a proximal atresia with a distal fistula. And type D is where you have a double fistula. See, there is a fistula between the proximal fistula to trachea and distal esophagus to trachea. So this is called type D or a double fistula. And type E is a condition where there is a connection between the proximal and the distal esophagus, but there is also fistula. So type is basically, it is actually fistula which is present. Atresia കാര്യമായിട്ടില്ല. There is a connection, but there is also fistula. This is called the H-type fistula as well. So there will be a question. So നമ്മൾ NG tube വിട്ടാൽ, because of this atresia, the NG tube cannot pass beyond this. NG tube will usually go through the esophagus, it should come to the stomach. But because of this atresia, the NG tube will get coiled, it will touch the lumen, it will get coiled inside. The only tracheoesophageal fistula type where the NG tube can pass through is the type E type, where the NG tube can pass through this opening into the stomach. So very important. A type of tricuspid fistula where NG tube can pass as a type E type of NG tube fistula. The most common type is type C, distal fistula with a proximal atresia. Okay. So this is the classical coiling of within the percussative fistula. So I think I'll wind up with the last two questions. A term newborn is found in distress after birth on examination. Grunt with a rate of 84 permanent subposal retractions, no sign of a reduced airentry, what is the down score? So down score on the rainbow, that is another thing which this is basically a thing which we try to stratify respiratory distress in newborns. So basically, you rate them in the 0, 1, or 2 based on the respiratory rate, cyanosis, retractions, grunting, and air entry. So in this case, you have a grunting is audible, which means it belongs to the stage 2, so score 2, which means the grunting is audible without stethoscope is 2. Severe retractions belongs to grade 2, that is 2, that is 2 plus 2 is 4, and but no cyanosis, no air entry reduction between 0 and 0, and respiratory rate of 84, which is 2. So the total score is going to be 6. So this question is also important. There is another scoring which is called Silverman-Anderson score again. You should remember this grading as well. This is based on 4 criteria, 5 criteria: upper chest retractions, lower chest retractions, preferred retractions, near dilatation, and expiratory grunt. I'm not explaining them in detail. You should know this as well because this has been asked time and time again. All of this in nephrotic syndrome in children except. So from this question, it's very obvious. Nephrotic syndrome, you know that edema is there, hyperlipidemia, but there is no hyperalbuminemia. Hyperalbuminemia is a feature of nephrotic syndrome. Other than proteinuria, proteinuria leads to hyperalbuminemia. So the answer is going to be C. So if a child presents you with edema and gross hematuria with dysmorphic RBCs and history of URTI 4 weeks back with decreased T3 levels, then the answer is going to be post streptococcal glomerulonephritis. So 4 കാര്യങ്ങളുണ്ട്. PSGN or PIGN is also called post streptococcal glomerulonephritis or post infectious glomerulonephritis. Will usually have a preceding upper respiratory tract infection which will progress to a kidney nephritis, inflammation of the kidney around the period of 3 to 4 weeks. And a predominant investigation will be decreased C3 levels with a microscopy showing dysmorphic RBCs. Similarly, if they give a question with recurrent gross hematuria for a child with no burning excretion of pyuria, which rules out a UTI, and C3 levels were normal. So the most common cause of recurrent gross hematuria in a child, and this happens with normal C3 levels, is something called IgA nephropathy. IgA nephropathy can happen immediately after a URTI and presents with macroscopic hematuria. It is a DDF gross hematuria. Okay. PSGN will usually have microscopic hematuria with proteinuria and develops 1 to 2 weeks after a URTI. A 1-year-old female child with macular rash of the jaw spreading to the trunk and to the third day without desquamation and tender post-oral lymphadenopathy. So whenever you find a maculopapular rash, it starts from the jaw to the trunk. You can rule out chickenpox. You can also rule out Roseola infantum because both of this usually predominantly starts from the trunk and then spreads centripetally. But if it starts from the face into the tongue, it can either be measles, erythema infectiosum, but they have not mentioned the classical description of measles, which is called Koplik spot. So what is Koplik spot? Is bluish white spots found in the oral mucosa, which starts as the antecedent marker of measles rash. And measles rash usually takes around 5 to 7 days to clear. Immediate clearing of a rash with a background of 5 fever is a very possible diagnosis of erythema infectiosum, which is due to parvovirus B19, and the baby will typically have this appearance, which is called as a slabbed cheek. Karnatadicha appearance, what is called as a slabbed cheek appearance. So most common cause of non-syndromic congenital sensorineural hearing losses. Again, a very frequently asked question, it is going to be CMV. CMV also will have periventricular calcification. Also remember toxoplasmosis triad and rubella triad. If they give you a scenario with baby having hydrocephalus, chororetinitis, and intracanal calcification, think about toxoplasmosis as the primary DD. So hydrocephalus, chororetinitis, and calcification. Rubella syndrome, congenital rubella, on the other hand, the baby will have deafness, sensorineural deafness and down. Cataract and also glaucoma is also possible. Most commonly, ophthalmic abnormality is going to be cataract. And cardiac defects, most common is going to be PDA. Second most common defect is peripheral pulmonary artery stenosis. So these scenarios can also be given. So you should remember the triad of rubella and syndrome. So coming to the last two questions. So a 2-year-old child has periodic episodes of cyanosis, relieved usually by squatting. Chest X-ray shows a boot-shaped heart with easily showing a right axis deviation. Which of the following will not be typically seen in this child? So this is obviously a boot-shaped heart with right axis deviation with a 2-year-old child having cyanotic spell is typically a description of what tetralogy of Fallot categorized by right ventricular hypertrophy, right ventricular peripheral pulmonary artery stenosis, a non-restrictive ventricular septal defect, and overriding of aorta. So overriding of aorta under right ventricular outflow tract obstruction under, but there will not be any left ventricular outflow tract obstruction. So this is the odd one out in TOF. So in TOF, you can notice that this is the X-ray. They usually have a boot-shaped heart. This happens because of the right ventricle getting hypertrophy. Ivideയാണ് right ventricle in the X-ray, but right ventricle is not commonly appreciated. When the right ventricle is hypertrophied, it pushes the apex, the left ventricle, to the side. So the apex is upturned, which makes it looks like a boot. So this upturned apex, because of right ventricular hypertrophy, makes it looks like a boot. And at the same time, the pulmonary trunk is stenosed, right? The pulmonary hyperplasia stenosis, which makes it look like a concavity here. So this concavity is due to pulmonary stenosis or hypoplasia with the upturned apex, leading to the appearance of a boot-shaped heart, a classical description of the tetralogy of Fallot. So these are the four classical things. There is pulmonary stenosis, which and a right ventricular hypertrophy. So what happens? There will be a difficulty in pushing the blood from right ventricular hypertrophy into the pulmonary artery, and because of which the decreased circulation to the pulmonary artery to the lungs. So there will be decreased blood flow to the lungs. And at the same time, there will be a ventricular septal defect, which will result in mixing up of blood between the oxygenation side and the deoxygenated side. And this mixing up of the blood and the aorta starts from the VSP. So this deox blood is being pumped into the aorta in the systemic circulation. So there are four basic defects in TOF because this is very important. So you can find that there is a non-restrictive VSP. Two ventricles under a connection. You can see this is the left ventricle, this is the right ventricle. So there is a connection between the left and the right ventricle, because of which there is a mixing up of blood between both the side of the ventricles. And there is also aorta which is being shifted. Normally aorta opens into the left ventricle, but here the aorta opens into the ventricular septal defect. And there is also a pulmonary stent, right ventricular hypertrophy. Okay, so because of the aorta being pushed to the VSP, the mixing up of blood happens here, and all the deox blood, the mixed blood will go to the aorta. So aorta blood carry, the aorta will carry blood to the systemic circulation, because of which deoxygenated blood can go to systemic circulation along with oxygenated blood. So this mixed blood going into systemic circulation will cause cyanosis. And due to this pulmonary stenosis, decreased quantity of blood will go to the lungs. So the lung fields will be oligemic. The baby can have cyanosis, and this will be worsened excessively when the baby is crying heavily or feeding when there is a significant stenosis happening. So അതുകൊണ്ടാണ് they present with cyanotic spells. Now this is an X-ray of another X-ray which we call to be the egg on string appearance. This is classically a description of transposition of great arteries where the LA is largely dilated. So PGL, what happens? Normally, artery and the left ventricle will give way to the aorta. So if the right ventricle gives way to aorta and left ventricle gives way to pulmonary artery, that is called TGA. There will be parallel circulation being established, which cannot function without a opening, or a VST or a PDA or a PSO has to be there for it to function. So in TGA, the LA is grossly dilated, which will lead to this appearance of this egg on string appearance. And this is a classical snowman description. The figure of it appearance which you see in supracardiac TAPVC, which happens due to massive dilated right atrium and the superior vena cava. Okay. And this sign, the figure of 3 sign and rib notching, is a sign of coarctation of aorta, which happens due to narrowing of the aorta at some point of time. So the figure of 3 sign means there's a narrowing of the aorta, which you can see like this. And there will be rib notching because intercostal arteries will be activated. Since aorta is not functioning properly, blood supply has to be established with intercostal arteries, and that will lead to cause rib notching. Yeah, that's why intercostal artery becoming dominant. Okay. So I think I will wind up here. So I think it was a long talk and I had to rush through the last portions, but basically just all the topics which I've discussed here are predominantly frequently asked questions, and all these questions are previous MCQs which have been asked. So just make it a practice when you're going for pediatrics. It has a low weightage, but just make it a practice to at least go through all the topics which I've mentioned here when you are going to attend the exam. I think this much is more than enough to this is more than enough to track at least more than 80% of the answers in pediatrics. Okay? Thank you so much, I guess. Thank you for listening. Thank you for your patience. Thank you, everyone.